আমাদের যে নুরানো স্যার এক্সডিজি ফার্মাকোলজির যে আমাদের যে হেড ছিলেন ডিজি স্যার, উনি তো বোধহয়
খারাপ না,
উনি তো বোধহয় এক্সপায়ার করেছেন নুরানো স্যার।
ও স্যার তো ভর্তি ছিল।
নুরানো
এক্সডিজি ফার্মাকোলজির প্রফেসর ছিলেন ঢাকা মেডিকেল।
আসসালামু আলাইকুম স্যার। স্যার ভালো আছেন স্যার?
আরিফ
স্যার ভালো আছেন স্যার?
ওয়েলকাম আরিফ।
থ্যাংক ইউ স্যার।
এই নুরানো স্যার কি মারা গেছেন?
অসুস্থ ছিলেন জানতাম, মারা যাওয়ার খবরটা শুনি নাই।
না, আজকে ফেসবুকে দেখেছি, আজকে ফেসবুকে আজকে সকালে বোধহয়
যেই এফেক্টেড হচ্ছে কি আর বাঁচতেছে না কি
বয়স্ক 50 প্লাসই তো মোর সাসেপ্টেবল দেখা যাচ্ছে 60 থেকে।
আরে এটাই সালফিট জামান ডট দেখায়ও না 55
হ্যাঁ স্যার, ওই 50 টু 60 পরিসংখ্যানে দেখা যাচ্ছে 50 টু 60 কাট হয়ে যাচ্ছে বেশি।
সবাইকে
আচ্ছা, আমরা শুরু করি স্যার। আমরা অলরেডি 10 মিনিট। আসসালামু আলাইকুম স্যার। Dear participants, respective panelists, especially Professor Atahar sir, thank you sir being with us. The second class, sir. Everybody are waiting for your class. I think ventricular tachycardia is the most important and regular practice in our CCU, ICU. Everybody are benefited from lecture. Welcome you all. Professor Wadud sir, please give your comments.
Assalamu alaikum everybody. Wish everybody is safe at home or wherever you are. Today we are going to talk about ventricular tachycardia, and the presenter is none other than Professor Atahar. He is a pioneer in popularizing ECG in this country, and he has a special mannerism of making things easy, funny, and making it to your heart. Ladies and gentlemen, let's welcome Professor Atahar. Atahar bhai, over to you.
Thank you very much, everybody, and thank you, Professor Abdul Wadud Chowdhury, for your nice and excellent introduction. And thank you, the organizer, particularly Dr. Mohsin, Ahmed, and Abdul Wadud Chowdhury, for giving me chance to talk in such an excellent forum, this virtual classroom. So can I start, Mohsin? Hello?
Yes, sir, you can start your presentation,
Yeah.
sir, please, sir.
Yes, again, welcome every participants. This is about the ventricular tachycardia. I think everybody participating in this session knows about this disease. Ventricular tachycardia, particularly, this is itself is a disease, always it complicates many other cardiac diseases. So this is one of the very important diseases because most of the cardiac patients, particularly at their terminal event, whether it is related to this or not, ultimately goes through this pathway, either the ventricular tachycardia or the ventricular fibrillation, and particularly any of the ventricular arrhythmias as a group. So this is very important. But before going to start about the ventricular tachycardia, I want to give some anatomical concept about the ventricular tachycardia, because simply we know the ventricular tachycardia originates from ventricle. From which structure of the ventricle? Ventricle is a big structure. There's a left ventricle, right ventricle, septum, myocardium, conduction system, pericardium, everything. So which part of the ventricle participates in the production, that is the development of the ventricular tachycardia? These are the anatomical substrate. That is the ventricular myocardium. Definitely it is, everybody you know that is the ventricular myocardium is the most important anatomical structure participating in development of this tachycardia. Then the conduction system also, there is ventricular tachycardia also can arise from the part of the conduction system, either from the His bundle branches or the Purkinje system. Interestingly, the ventricular tachycardia can arise from the valve cusp, either the aortic valve cusp or the mitral valve cusp, like this valve cusp. And again, the ventricular tachycardia may be from the endocardial side of the heart or from the epicardial side of the heart. So these are the anatomical perspectives about the ventricular tachycardia. When we analyze the ventricular tachycardia, particularly if we try to classify the ventricular tachycardia in pinpoint, then we have to describe the ventricular tachycardia anatomically from which part of the tachycardia arises. So this is important about the ventricular tachycardia. And I think everybody is interested to know about the groups of the tachycardia, because as you know, clinically, as a whole, that is the tachycardia can be either tachyarrhythmia or the bradyarrhythmia, you know. And ventricular tachycardia is this group. That is, it is a subgroup of the that is a tachyarrhythmia. So ventricular tachycardia is an example of the tachyarrhythmias. And from the clinical aspect, tachy versus brady, and ventricular tachycardia is one of the example of the tachyarrhythmias. But unless we classify it ECG with ECG, we cannot say whether it is from which anatomical part of the heart it arises. So ECG classification is very important. From ECG, this tachycardia can be divided into the narrow complex tachycardia and the wide complex tachycardia. Again, the ventricular tachycardia is an example of the wide complex tachycardia. There is rare example that the ventricular tachycardia can be the narrow complex, but almost always ventricular tachycardia is the wide complex tachycardia. And 80% of the wide complex tachycardia are due to the ventricular tachycardia. These are the groups of the tachycardia who is under this wide complex tachycardia. So again, by ECG, ventricular tachycardia falls under the headings of the wide complex tachycardia. And wide complex tachycardia groups, these are the groups. Most of the time, this is the ventricular tachycardia. This is the primary tachycardia. That is, ventricular tachycardia develops as a primary event, but ventricular tachycardia can degenerate into other forms. So these are the other tachycardia, the ventricular fibrillation, torsades de pointes, this is the polymorphic tachycardia, but sometimes it may be the bradyarrhythmia. So ventricular arrhythmias as a whole, not the ventricular tachycardia. I want to emphasize, I am talking about the ventricular arrhythmias. The ventricular arrhythmias includes these groups. There is the ventricular tachycardia, primary ventricular fibrillation, polymorphic VT, or the bradyarrhythmias. But the ventricular tachycardia is not unstable. Most of the time, this tachycardia degenerate into the other form. And this is the reason, this is called the malignant arrhythmia. As because this is the ventricular tachycardia. Due to depending on several conditions, this tachycardia may not be stable. It can degenerate into ventricular fibrillation. And this ventricular fibrillation can lead to the development of the asystole. So this is the cycle. There is ventricular tachycardia to ventricular fibrillation and asystole. Once the asystole develops, unless there is intervention, there is no chance to back. So this is the cycle. This is the cycle. This is just like the storm. It can cycles. So ventricular tachycardia may be the primary event, or ventricular tachycardia may remain as the ventricular tachycardia, or ventricular tachycardia may degenerate into ventricular fibrillation and the ventricular asystole. And this is reason it is called the malignant arrhythmias. These are the groups of the malignant arrhythmias. And among these ventricular arrhythmias, I will discuss about the ventricular tachycardia only, not the ventricular arrhythmias as a whole, ventricular tachycardia. So there are some definitions, particularly ventricular tachycardia. 3 or more premature ventricular complexes at the rate of 120 beat in succession, not in isolated, is called the ventricular tachycardia. But this 120 in ACC-AHA guideline, it is mentioned as 100. So the rate is either 100 or 120. There are some controversy, but 3 or more PVCs in succession, particularly in this talk, I will describe it as the 120 beats per minute is called the ventricular tachycardia. Non-sustained ventricular tachycardia, this is called when the tachycardia lasts less than 30 seconds, usually self-terminated. That is self-terminated tachycardia lasting less than 30 seconds is called the non-sustained ventricular tachycardia. sustained ventricular tachycardia when last more than 30 seconds or less than 30 seconds if received DC cardio shock. So this is the sustained tachycardia, that is the lasting more than 30 seconds or less than 30 seconds when it is reverted by the DC cardioversion. Accelerated idioventricular rhythm. This is the controversial area, that is the rate between 120 and 100. If I accept this 120 rate, then this 100 to 120 is considered the accelerated idioventricular rhythm. Or if I consider the rate 100, then there will be no term, that is AIVR. So if I accept this term, that is the 120, then AIVR, accelerated idioventricular rhythm, that is the PVC rate in between 100 to 120. There is another definition, is called the pulseless VT. That is when along with the VT there will be hemodynamic collapse or the patient needs the cardioversion. It is called the pulseless VT. And refractory VT, when VT cannot be reverted to sinus rhythm despite medication or by cardioversion. Applying the cardioversion, sinus rhythm for a brief period, then again VT. Again shock, again VT. So these are the refractory VT. No medication, no shock works. So this is called the refractory VT. Sometimes we experience these kinds of the VT. Another is the VT storm. That is 3 or more VT episodes over the 24 hours time. This is called the VT shocks, VT storm. Particularly it happens in a patient who has got the Icd implanted. Some other definitions also, ventricular flutter. That is ventricular arrhythmia at the rate of 300 beats per minute, which is sinusoidal appearance. There is no in-between isoelectric line. This is rare and unstable. If we see the ventricular flutter for a brief period of time, it usually degenerates from the ventricular tachycardia and again degenerates into ventricular fibrillation. So this is not the stable arrhythmia. We can see in a clinical practice in a patient for a brief period of time. So this is the reason we are not describing it separately. So this is the ventricular flutter. And ventricular fibrillation, you know, this is the chaotic beat, rapid, grossly irregular electrical activity with variability in rate and waveform. These are seems to be the ventricular in origin. These are not atrial origin from their morphology, but there is no organized QRS complex. We cannot see which one is QR, which one is R, which one is T, which one is ST segment. So this is the grossly irregular electrical activity. But we are sure this is arising from the ventricle as because its shape decides. So this is the ventricular fibrillation. And sudden cardiac, that is the structural heart disease. This is an important term we have to clarify. It is structural heart disease. In guidelines, it is defined as it encompasses, that is ischemic heart disease, cardiomyopathy, valvular heart disease, and the congenital heart disease. If these 4 categories of disease are absent, then we can say this patient does not have the structural heart disease. Or either of these diseases is present, this patient has got the structural heart disease. So this is the way we can define the presence or absence of the structural heart disease. And by the blood pressure, we can define the patient as the pulseless VT or the stable VT. And there is another term which is called the channelopathy, that is genetic abnormality of the ion channel. So these are the terms related to the descriptions of the ventricular tachycardia. So some other definition, that is the hemodynamically stable, that is the hemodynamically stable VT. Sometimes we see that is the patient may be either asymptomatic or can complain only minor palpitation. This is called the hemodynamically stable. Or unstable if the patient develops the syncope or cardiac arrest and the patient does not have the pulse and the blood pressure. So it is called the unstable VT. Again, the ventricular tachycardia can be defined by the ECG. That is either it can be monomorphic VT, or it can be polymorphic VT, or it can be torsades fundis, or it can be bidirectional VT. So there are good numbers of terminology or the definitions related to the descriptions of the ventricular tachycardia. Epidemiology, how common the disease is. Actually, the exact prevalence of the ventricular tachycardia is very difficult to difficult to diagnose, as because there are a lot of limitation. I will not discuss that issue, but there are one way by Holter test among the general population or the subgroups of the people, we can see is there any chance of the ventricular tachycardia. But it is simple that Holter is very much not suitable for detection of the unstable ventricular tachycardia, because if the patient is hemodynamically unstable, the patient will seek the treatment. So by Holter examinations, we can detect the prevalence of the non-sustained ventricular tachycardia. So it is a broad assumptions that what is the prevalence of the non-sustained ventricular tachycardia. Among the healthy individuals, about 0 to 3% of the people, if we randomly do the Holter test among the general population, up to 3% of the patient may show that is the non-sustained VT, but they are asymptomatic. Again, particularly the most common cause is the myocardial infarction, and myocardial infarction within 48 hours, it is about 75% of the patient may have the ventricular tachycardia. We do the Holter, we don't do, but if we do, we can see nearly about 2/3 of the patient may have the non-sustained ventricular tachycardia that can be detected by the Holter. And MI after the 1 month, if the patient has got the history of the thrombolysis, the non-sustained VT is less, nearly 7%. But if the patient does not have the thrombolysis or the reperfusion, rate is slightly higher, that is a 10%. And another subgroup is the patient with the heart failure, particularly ejection fraction less than 40%. Whether they are symptomatic or not, these groups of the patient has got significant number of the that is the non-sustained VT incidence, nearly about 30 to 75%. And among the other structural heart disease, that is the DCM and ACM, that is 30 to 80% or 25% of the patient. So this is some gross assumption about the prevalence of the non-sustained VT among the general population, the subgroups of the patient. But there are some subgroups of the patient. Among them, we can see what is the prevalence of the sustained VT, particularly in case of the cardiac arrest. The patient who has cardiac arrest, who develops, whether the patient survives or not, as a cause of the cardiac arrest, it is about 50%. That is 50% of the cardiac arrest is due to the ventricular tachycardia, and the other is due to the ventricular fibrillation or the cardiac asystole. So this is the incidence among the cardiac arrest patient. And MI within 48 hours as a whole, sustained VT. In case of the non-sustained VT, it was 75%, but sustained VT is about 15%. And among the patient who has got the primary PCI, nearly 7.5% of the patient may have the sustained VT after the primary PCI. And W, that is the wide complex tachycardia, whatever may be the etiology, among the wide complex tachycardia, who has got the wide complex tachycardia by ECG, 80% patient will have this sustained VT. So this is some idea about the prevalence of the sustained ventricular tachycardia. Again, the prevalence of the disease again can be some give idea as per the age of the patients. That is the age of the general population. We see younger patient has got particularly chances of the channelopathies, genetic cause of the ventricular tachycardia. But as age advances, there is more chances of the coronary artery disease or the dilated cardiomyopathy or some other structural heart disease. So this is more important. As age advances, the other structural heart disease predominates. But as age is less, younger people, structurally normal heart, particularly the genetic disease, are more important. But the etiology of the VT. The etiology of the VT can be classified into two groups. That is the VT with the structural heart disease or VT without the structural heart disease. I have defined earlier that as per guidelines says, structural heart disease means presence of the ischemic heart disease, valvular heart disease, congenital heart disease, or the cardiomyopathy. Absence of these four diseases means there is no structural heart disease. So there is a group of the structural heart disease that can be responsible for the VT. CAD means coronary artery disease, DCM, ACM, LV non-compaction cardiomyopathy, Tokub-2 cardiomyopathy, ARVD, toxic cardiomyopathy. This is getting more and more importance nowadays because of wide use of the cytotoxic drug. This is one of the important cause of the that is the ventricular tachycardia, particularly those who receive the cytotoxic drugs and develop the cardiomyopathy. Then infiltrative cardiomyopathy, particularly among the patients with the sarcoidosis. These are the rare, uncommon, but curable cause of the ventricular tachycardia, that is the sarcoidosis. And post-operative scar, this is definitely one of the important cause. Those who have got the congenital valvular heart disease or the CABG underwent operations, and there is a scar, and that scar is a structural problem, and that can initiate the VT. So these are the causes of the structural causes of the VT. And there is some idiopathic cause, that is these groups of the patient does not have these four mentioned diseases. So these are called the idiopathic or the structurally heart. That is the outflow tract VT, fascicular VT, channelopathy, or the early repolarization syndrome. So these are the groups of the diseases. Those of the patient does not have the structural heart disease. But among all the diseases, if we summarize, we can see 80% of the diseases, that is 80% of the VT is due to the coronary artery disease, and 15% of the VT is due to the cardiomyopathy, and rest 5% includes all other causes, including the channelopathy. So coronary artery disease and cardiomyopathy, these two diseases combinedly accounts 95% of the causes of the VT, and all the other causes falls under the 5% causes. So cardiomyopathy and the coronary artery disease are the two most important causes of the ventricular tachycardia. But the patient, those we are labeling as the structurally normal heart, really are they structurally normal? Does not have there any problem? No, this is not true, as because by definition, they don't have the ischemic heart disease, cardiomyopathy, valvular disease, or congenital heart disease, but they have got problems at their cellular level, and particularly at their ion channel level. This moving, you see, this is the one of the three-dimensional figures of the ion channel. There is some problem, there is some mutation, there is some transport mechanism abnormalities in these groups of the patients, particularly the channelopathies. So the structurally normal heart, idiopathic ventricular tachycardia, they are not truly idiopathic. We know something about that pathology. We possibly don't know everything, but we know something about the pathology. That is, they are going to have the channelopathy. But these are not detectable by the echocardiography or something, some other big test. This is also, there is another examples of the idiopathic VT is the fascicular VT. They don't have the problems in the channel, but they have got the connections between their fascicles. That is the reentry between the some parts of the conduction system, particularly the Hughes-Parkinson system of the fascicles. So this is also some kinds of the electrical abnormality. Structurally looks normal, but there is some electrical abnormality. And particularly, then other example is, this is one of the common entity, that is the outflow tract VT. They have got some abnormal automaticity at the cellular level, particularly at the outflow tract of the right ventricle or the left ventricle. So the idiopathic VTs are not truly idiopathic. We don't know everything about the pathology, but we know something about the etiology that is not there truly that is idiopathic. Then the ventricular arrhythmias mechanism, particularly the ventricular tachycardias mechanism. As for example, for every tachycardias, not for all arrhythmias, particularly tachycardias, these are the three mechanisms, that is the abnormal automaticity, reentrant mechanism, and the triggered mechanism. These three are the mechanism for the ventricular, that is any kinds of the tachyarrhythmia, not for the bradyarrhythmia. These are the mechanism for the tachyarrhythmias. And these all kinds of the tachyarrhythmias, that is all three kinds of the mechanism can participate for the development of the ventricular tachycardia. Like this is the example of the action potential. This action potential, you know, this is the depolarization phase 0. This is phase 2, that is the plateau phase. This is the phase 3 and this is the phase 4. Then triggered activity means that is earlier depolarization. You know, this is the phase 3 part of the repolarization. That is, repolarization starts from the phase 1, phase 2, phase 3. And this is phase 4 is the resting membrane potential, that at this time the heart regains the resting membrane potential. So phase 1, phase 2 and phase 3 are the repolarization. And this is the relative refractory period. At this time, if the stimulus is sufficient enough, the heart can be depolarized. So that is the triggered activities means that is the depolarization at the latter part of the repolarization or at the early part of the depolarization. That is the phase 4. During this time, depolarization is called the triggered activity. That is, this is again early after depolarization and late after depolarization. But what is the message? Message is that during this relative refractory period, that is phase 3 of the action potential, heart can be depolarized, which is called the triggered activity. And during phase 4, this is the time when heart reestablishes their resting membrane potential. But some of the pacemaker cell, particularly the sinoatrial nodal cell, they have got excellent capacity of going spontaneous depolarization during this time. If this capacity of the SA node develops in other parts of the heart where it is not available, particularly myocardium, this is called the abnormal automaticity. That is, the automaticity what the SA node has, if develops in other parts of the heart where it is usually absent, is the abnormal automaticity. That is spontaneous phase 4 depolarization of the heart. So this is again one of the mechanisms for the development of the ventricular tachycardia. These concepts are important as because these ideas are needed, particularly during the selection of the drugs, as because most of the drugs works as per the mechanism of their action potential. So this is the reason why I am describing these kinds of the mechanism of the heart, as because it sounds very clumsy, but it is essential for understanding about the treatment of the ventricular tachycardia. There is another mechanism which is called the reentry mechanism. This is the commonest mechanism. That is a reentry mechanism. Like other tachycardias, most of the tachyarrhythmias are due to the reentry mechanism, either supraventricular, ventricular. The ventricular tachycardia also due to the reentry mechanism. But reentry definitely one of the most important mechanism. But other two mechanisms are also important. And for the reentry mechanism to develop, it needs two pathways. One pathway will be fast and another pathway will be slow. And both the pathways will be connected proximally and distally. And one ectopic impulse like this will come at the proximal end of the connection of the two pathways, and that will initiate the reentry mechanism, reciprocating mechanism. This is called the basic principles of the reentry circuit. So these three are all the mechanisms for responsible for the development of the ventricular tachycardia. Particularly, not this electrical mechanism for the ventricular tachycardia. That is actually what I am telling. This electrical mechanism, that is actually as a result of the triggering effect. Some kinds of the trigger, that is the stimuli or the electrolyte or something else, that causes these kinds of the abnormalities. But the patient needs some of the structural abnormalities of their heart. That is called the substrate. So any kinds of the tachyarrhythmia, especially when the ventricular tachycardia to develop, it needs two things. That is the substrate within the heart and the triggering factor. The substrate within the heart, that is the permanent problem. We have to remember it. We don't think only about the triggers. We have to think about the scar, that is the substrate also. That is the scar, fibrosis, or the abnormal mutant channels. These are the permanent problems of the heart. These are the substrate for the pathology for the development of the tachycardia. And on the top of the substrate, if the triggering mechanism comes, like the ischemia, electrolyte imbalance, or hypoxemia, or the drugs, then these kinds of the abnormality develops. So this is the message. For the tachycardia to develop, we need the substrate and some triggering factor. and the triggering factor over the substrate causes the electrical instability and the development of the ventricular tachycardia. So this is the basic pathogenesis of the ventricular tachycardia, and why the ventricular tachycardia is malignant in contrast to the supraventricular tachycardia. Most of the supraventricular tachycardia is not malignant, but when we describe the ventricular arrhythmias, we say these are the malignant arrhythmias. Why? What is the reason we call it malignant and supraventricular tachycardia is benign? As because most of the time when the ventricular tachycardia develops in a structurally abnormal heart, particularly on the background of the LV dysfunction, this LV dysfunction, that is poor LV function, cannot tolerate the fast ventricular rate, that is the fast ventricular tachycardia. As the rate increases, the pressure drops, that is causes the hypotension. And as the hypotension develops, there will be two outcomes. Either the VT will degenerate into the ventricular fibrillation, or the VT will degenerate into the agonal rhythm, and that will lead to the asystole. So this is the reason the patient develops the ventricular tachycardia, but after a few minutes, the ventricular tachycardia converted into either asystole through the agonal rhythm or into the ventricular fibrillation. So this is the reason. This is called the ventricular. This is reason. It's called the ventricular arrhythmias are the malignant, particularly the ventricular tachycardia. But this is not happens in all the cases, particularly in cases of the structurally normal heart. So what we say, ventricular arrhythmias as a whole are the group of the diseases, that is prevasive ventricular contraction, ventricular tachycardia, or the ventricular fibrillation. And the ventricular arrhythmias as a whole either may be asymptomatic, as for example in case of the premature ventricular complexes or some kinds of the non-sustained VT, or it may be fatal like the cardiac arrest. So this is the wide range of the presentation of the ventricular arrhythmias and wide range of the reasons for the ventricular arrhythmias. Among these, ventricular tachycardia is most important, as because most of the time these are the symptomatic, unlike the PVC. These are the symptomatics and they have got the malignant nature like this. That is, they can degenerate into the ventricular fibrillation or the asystole. So this is the reason. This is the ventricular tachycardia, and this ventricular tachycardia, as per I have described, have got chance to develop into the ventricular fibrillation, and this is the reason it is called the malignant ventricular arrhythmias. And the ventricular fibrillation can degenerate again into the asystole. Either VT can directly go to the asystole or can go to the asystole to the ventricular fibrillation. So these three arrhythmias are interrelated. That is, VT can go into either forms of the disease, and this is the reason it is called the malignant arrhythmias. But this malignant character is not present in case of the structurally normal heart, as because heart is structurally normal, LV function is okay. There is no chance of development of the hypotension except some special situation. So there is a less chance of the transformation into VT, that is the VA for the asystole. So this is reason the ventricular tachycardia is well tolerated in case of the structurally normal heart, but not always. It again depends upon the rate of the ventricular tachycardia. There are some special mechanisms I have to mention in case of some special subsets of the disease, particularly the commonest cause of the ventricular tachycardia, that is 80% cause is the ischemic heart disease. And among the ischemic heart disease, the myocardial infarction is the most important subset that I want to mention. What happens in case of the myocardial infarction? As for example, we see this is the myocardial infarction. This area is the infarct zone, and this area that is the healthy zone, and there is some border zone. So in an infarct heart, there are three areas, that is necrosed, border, and the healthy areas. And these three areas can do three kinds of the problem, particularly in case of the border zone. During acute ischemia, they can develop the abnormal automaticity, that is, ischemia causes abnormal permeability of the cell membrane, abnormal transport of the ions, and causes abnormal automaticity. Then can develop what I told earlier, that is, at this time, this is the area what the acenotal cell does. This area can develop that kind of the characters, that is spontaneous depolarization during the phase 4. That is called the abnormal automaticity. That is border area of the myocardial infarction. may develop the abnormal automaticity, particularly during acute ischemia. And AIVR, accelerated idioventricular rhythm, is the commonest arrhythmia that can develop from this area. Another is the triggered activity, that is the multiple re-entry. That is, this area again can develop multiple, that is the abnormal automaticity, what the patient develops can again, not only the depolarization, can also there may be abnormalities in the repolarization. And because of the multiple depolarization and the repolarization at the different cells can develop different kinds of the abnormalities. So there will be multiple micro reentry. And because of the multiple micro reentry, multiple kinds of the QRS complexes may develop. This is the basic mechanism. This is the basic physiology. This is the basic pathology of development of the torsades pointis, that is variations of the QRS complex in the different durations and the amplitude. This is the result. That is multiple reentry circuit because of the multiple kinds of the depolarizations at the different, that is the particular the infarct zone at the border zone. There is another is the reentry. This is very interesting. I think you want to understand this pathology. This is the histology of the infarctaria. You see, in a patient who has got the infarctaria after the 6 weeks, when there is development of the scar, the white area indicates the development of the scar. The red area development of the healthy myocardium. And between the scar and the healthy myocardium, there are some white at the, that is the insparsed area. So this is the border area. So the scar area, these are the non-conducting, non-contractile. They neither can produce electricity nor can conduct the electricity. But these are the healthy myocardium and this border area. So what we see, there is the 3 zones. These zones, there are some cells. They have got the less power of conduction. That is, conduction speed is less. They have got compared to this area, and they have got the in between. So there is the sub. There is the scar area fulfills all the criteria for development of the reentry. That is, there will be 2 pathways. One pathway like this area, and one pathway from here. 2 speed. They have got the less speed. They have got the fast speed. And they may be connected proximally and distally. If this criteria fulfills, they have got chance of the development of the reentry circuit. So this is the basic mechanism of what happens in case of the myocardial infection, particularly the scar-related VT, what we call the scar-related VT. The scar VT are always due to the reentry circuit, and this is the basic mechanism for development of the reentry circuit. So all the kinds, what I want to mention, for the ventricular tachycardia to develop, particularly in case of the myocardial infarction, all 3 mechanisms, either singly or in combination, at a particular time, one day may develop, they have got the reentry, another day may they develop the, that is the triggered activity. So all kinds of the mechanisms interplay in case of the coronary artery disease, particularly in case of the myocardial infarction and after development of the scar. And stability of VT in MI. This is again, depending upon the duration, that is time of onset of the myocardial infarction, all VT does not behave homogeneously. The development of the VT at a particular time can behave in a different way, particularly within first 48 hours of myocardial infarction, there is high chance of the degeneration. That is, during this time, the VT develops, it quickly degenerates into the ventricular fibrillation, as because there the membrane permeability is not stable. Still there is myocardial ischemia. So at this time, the ventricular fibrillation has got highest chance to develop into the, that is ventricular fibrillation. And late myocardial infarction, after 2 days, up to 6 weeks or more, as the days increases, as the scar develops, there is a less chance to degeneration into the ventricular fibrillation, but still may happen. But within the first 30 minutes, that is the dangerous time. That is the dangerous time. Within this time, even the,
Sir, unmute, sir. Atahar, sir, unmute. Okay, sir. Thank you.
Sorry. Okay, sorry. So, what I want to emphasize, that is particularly during the first 30 minutes of occlusion of the coronary arteries, that is the acute ischemia. This time is very dangerous, very dangerous, as because either the first arrhythmia may be the ventricular fibrillation, or if ventricular tachycardia develops, very unstable, very quickly descends into ventricular fibrillation. But another good news, there is a chance of still it is reversible. We cannot revert it. If we do the reperfusion earlier, there is a less chance of the development of the further ventricular ablation. So it is a two-way sword. That is very unstable, but again it is reversible, particularly during the first 30 minutes of the myocardial infarction. And not only the occlusion, again perfusion of the myocardium can be one of the cause for the ventricular tachycardia, particularly ischemia, that is the ischemic arrhythmia due to the acute occlusion, but reperfusion, excessive perfusion after occlusion, that is perfusion after occlusion, hibernating myocardium, again is the cause for the ventricular arrhythmias. Different kinds of the ventricular arrhythmia develops. Most common is the accelerated idioventricular rhythm, but may can develop also the non-sustained VT, sustained VT, ventricular fibrillation, or the PVC. But definitely common is the AI, that is the accelerated idioventricular rhythm. So what I want to emphasize, in contrast to our concept, in contrast to our belief, that is occlusion is the only cause, that is not true. Reperfusion after occlusion is again one of the important causes of the development of the VT, although they have got less chance to degeneration to the ventricular fibrillation in contrast to the other conditions. But still these are the causes of the VT. This is one of the example. This is one of the example of that is the ventricular arrhythmia in a patient who has got the reperfusion. This is what kind of the arrhythmia. By definition, these are all the premature ventricular complex, that is PVC at the regular rate, and by counting the regular rate, it is just that is just less than the 100. So depending upon the rate, its name will be. If the rate is more than 100, then it can be VT, or if it is rate than is in between 60 to 100, less than 60, it can be idioventricular rhythm, or in between the 60 to 100, it can be accelerated, that is the accelerated idioventricular rhythm. But as per definition of the guideline, the rate should be 100 to 120 for the accelerated ventricular rhythm to be defined. So these are the different kinds of the arrhythmias. What may be the name, but this is one of the example of the reperfusion arrhythmia that can develop out of the myocardial infarction. Not only the coronary artery disease, the other structural abnormalities of the heart. As for example, this is an example of the late ventricular hypertrophy. This seems to be the concentric hypertrophy. Both the septum and the free wall are concentrically hypertrophied. So this hypertrophy is one of the important cause for the development of the ventricular tachycardia. In case of the hypertrophic cardiomyopathy, it can be eccentric, that is asymmetric, but hypertrophy, whatever may be the concentric or eccentric, is the basic substrate for the development of the ventricular arrhythmia. What happens here? As because we see this is the increased mass of the ventricular, that is increased ventricular mass. Increased ventricular mass means increased amplitude of the QRS duration, that is increased amplitude of the QRS voltage, increased amplitude of the QRS duration, and more importantly, increased durations of the repolarization. So it is the abnormal repolarization, abnormal depolarization, what can happen in cases of hypertrophied heart. As for example, this is one of the histology in a patient of the hypertrophic cardiomyopathy. You see, again, like the myocardial infarction histology, we see these are the white areas, these are the fibrosis in between the myocytes. The myocytes are very big and bizarre. These are the desire. So that is desire arrangement of the myocardial fibers, and in between them there are some white areas, that is the fibrosis. So histologically there is fibrosis and desire and the big size myocardial cells, and these are the very important potential substrate. There is abnormal automatism may develop because of this big size of the myocardial cells. Reentry, as because I have explained earlier, that is due to the presence of histologically, that is fibrosed area at the normal area. So there will be different kinds of the speeds of the conduction. So there is every chance of development of the sustained reentry, and reentry is mechanism for the sustained VT. And because of the abnormal depolarization, there will be definitely abnormal repolarization, and abnormal repolarization is responsible for the development of the polymorphic VT. So this is the ventricular hypertrophic cardiomyopathy. What happens? They may have the PVC because of the abnormal automaticity, sustained VT because of the reentry, or the polymorphic VT because of the abnormal repolarization. But not only the structural abnormality, the other factor can also affect the repolarization of the heart. Like this is one of the example of the metabolic example. That is the example of the metabolic disease. Particularly, we can see in case of the drugs or the hypokalemia. This is a ECG of a patient with hypokalemia. We see there is widening of the QRS complex. What does it mean? What message it gives? There is increased duration. There is wide. There is prolonged. There is the prolonged QT interval. What does means? QT there is the chance of the relative refractory period. As for example, like this. This is one of the example of the action potential. This is action potential, and this is the ECG. You see the action potential and the ECG. This is the depolarization. R is the depolarization, and this is again the repolarization. And greater the duration of the action potential, greater will be the duration of the QT interval. Simple, very simple statistic. The widening of the QRS, what is, so this is the result. There is widening of the QRS, that is the action potential. There is widening of the action potential almost always due to lengthening of the repolarization, that is the repolarization. And the lengthening of the repolarization means that is the lengthening of the QT interval. So this is the result. What happens here? You see, there is the lengthening of the QRS interval, that is the action potential means lengthening of the QR interval, and lengthening of the QT interval means there is increased chance of development of the ventricular tachycardia, because there is further increase of the this line and this line shows there is further increase of the relative refractory period. As the relative refractory period is increased, as the relative refractory period is widened, there is a chance that is the ectopic beat will fall on these groups, and they can initiate the ventricular tachycardia. What happens in case of the long, that is the in case of long QT syndrome? And I have already told how this long QT syndrome develop into polymorphic VT. So this is one of the metabolic cause. That is, metabolic factors can also affect the repolarization of the ventricle, repolarization of the heart, and they can initiate the ventricular arrhythmia. Particularly, the one of the example is the torsionis pointis, and this is the ectopic that falls into the widened QT interval, that is lengthened QT interval. This vulnerable period, that is later part of the T, and this is the relative refractory period. This is the area here, so that can initiate the ventricular. If the stimulus is sufficient, that can initiate the ventricular tachycardia. This is the mechanism how the lengthening of the QT interval initiates the ventricular arrhythmia. But the triggering factor is the ectopic. Remember, please. Without ectopic, it cannot happen. The triggering factor should be the ectopic beat. That should fall on this time. Then the presentation of the ventricular tachycardia. The presentation of the ventricular tachycardia, most of the time it is the cause related. That is, it may be asymptomatic. Particularly, I have already told there is a 3% of the general population may have the non-sustained ventricular tachycardia, and they may be asymptomatic. So non-sustained ventricular tachycardia may not be symptomatic. They can be asymptomatic, and there are asymptomatic non-sustained ventricular, even in the coronary disease of the hypertrophic cardiomyopathy. So the patient may be asymptomatic, or they may complain the palpitation, or the patient may complain the syncope, or the patient may complain the neck fullness, or the patient may present it with the sudden cardiac death. So these are the common presentations of a patient of the ventricular tachycardia, and there may be some complaint according to the cause. That is, whether the patient is develops with the presented with the acute coronary syndrome, or carditis, or electrolyte disorder, or the sleep apnea. So these are the some common causes of the presentation. That is, presentation will be as per their pathology and some kind of the underlying cause. So these are the presentations of the patient. And how to evaluate these groups of the patient? The history is not unimportant for the evaluation of the diagnosis of the ventricular tachycardia, as because there may be some of the groups of the patient there should be a family history of the cellulopathies, that is particularly the long QT syndrome, or the patient may give. These are the rare, but these are very much important for the diagnostic evaluation. The patient may have the history of the neuromuscular disease, or the patient may have the cluster of the history of the cardiomyopathy, particularly the hypertrophic cardiomyopathy. There are some families where most of the members of the family members have the hypertrophic cardiomyopathy. Even dilated cardiomyopathy may also. So these are the importance of the family, that is the history. And other parts of the history also, whether the patient develops syncope or cardiac arrest previously. So there are some important aspects of the history for evaluation of the ventricular tachycardia. So these are the important point. And examination, also not unimportant. A patient who has got the ventricular tachycardia, particularly the pulse and blood pressure, these two are very crucial for differentiating the patient is whether stable or unstable. That is very important decision for management of the patient. So pulse and blood pressure, very, very, very important, as because these two things helps to differentiate between the VT with stable or VT that is the hemodynamic stable or the hemodynamic unstable. So these are the also very important point, that is the examination. And jugular venous pressure, this is also important. That is jugular venous pulse examination helps to differentiate many of the times between the SVT and the VT. And also we have to auscultate the patient, as because that is the presence of the murmur, bruit. This helps to diagnose that is the underlying cause of the patient. If the patient has got the substructural heart disease, particularly murmur and the bruit, can help to take decision what kind of the structural heart disease patient may have. So, or the development of the new murmur, particularly in case of the ischemic heart disease. The patient did not have the murmur previously. I know the patient, but the patient developed the murmur new. So there is a chance of that the new murmur may be the either the myocarditis or the coronary artery disease. So these are the importance of the examination of the patient presented with the ventricular tachycardia. And differential diagnosis, this is very important. That is for the diagnosis of the patients of the ventricular tachycardia, differential diagnosis, particularly symptom. Again, symptom is also important. The most of the time, what we want to differentiate, the first point is differentiation is that whether this patient has got, as because we have seen the patient, we have examined the patient, and we have seen the ECG. Now we are confused whether the patient has got the supraventricular tachycardia or the ventricular tachycardia. So the first important point, that is whether the patient has got the supraventricular tachycardia or the ventricular tachycardia. And for this regard, symptom is also one of the important, as because this is one of the patient who has got the syncope. That is this is definitely I'm thinking, if this patient has got the white complex tachycardia, there is a chance that is the patient has got the ventricular tachycardia. And the outcome of the ventricular tachycardia depends on the LV function. But if the syncope is recurrent several times over the last 3 years, it is unlikely to be VT. This is very important. That is VT, every time the patient will survive, this is unlikely. That is, if the history of the syncope several times and the history is more than 3 years, there is a chance the patient may have got the SVT from the history. So this is one of the importance of the history. And this is importance of the sign. As because you see, this is the neck, and you see something that is the abnormal waves, that is the venous pulsation in the neck, and you see the regular narrow complex tachycardia below, and this is abnormal cannon waves, that is both the atrial and ventricular contracting simultaneously. The atrial contraction waves reflected back into the neck, and that you can see, and the rate of the wave as per rate of the SVT, and when there is a chance of the overriding, that is the collision between the that is the atrial and ventricular contraction. So regular cannon waves, that is giant A wave in neck, is an important finding in case of tachyarrhythmias. And if it is regular, it is AVNRT. But it can again may be irregular. Like the figure on the right side, we can see there is also cannon wave, but this is not rhythmic, this is not regular, and the patient ECG has got the white complex tachycardia. So this is almost sure that this is the VT. So there is the importance of the examination of the patient also, particularly that there is neck vein. That is the how we can see by the seeing the A waves, giant A waves, we can differentiate with the VT and the SVT. And this is some of the points for differentiating between the VT versus SVT. That is, again, this is also important, particularly the history of MI in favor of the VT, congestive cardiac in favor of the VT, angina in favor of the VT, recurrent episode, that is the SVT, duration of the illness more than 3 years, SVT. So these are the points by which we can differentiate between the SVT from the VT. And not only the history and the sign, finally this is the ECG, we have to consult whether this rhythm is VT or SVT. As per example, the upper one, this is the narrow regular complex tachycardia. It is SVT. At least sure this should not be VT, as because narrow complex tachycardia should not be VT. But the wide complex tachycardia usually VT. In 80% cases it is VT, but in 20% cases there are other probabilities, like that is SVT with aberrancy, or SVT with bundle branch block, or maybe pre-excitation. So these are the 4, that is differential diagnosis of the wide complex tachycardia. So we have to think about the probabilities, not only that we can see, we can take help from the symptom and sign, but we have to take final decision from the ECG for the working diagnosis of the patient and for the management of the patient. So these are the 2 examples. This is one of the example. Some other the other maneuvers, particularly injection of the adenosine, helps to differentiate between the wide complex tachycardia. This is one of the example. This is the regular wide complex tachycardia. I am not sure what kind of tachycardia it may be, but after giving adenosine, the patient develops these kinds of the rhythm. That is totally normal rhythm. So it is confirmed. I am now sure, absolutely sure, there's irregular wide complex tachycardia is due to the supraventricular tachycardia. That was due to the aberrancy. This rhythm was due to the aberrancy, that is wide complex tachycardia with RVM morphology. This was aberrancy, as because aberrant, that is the adenosine injection terminated this aberrancy, converted to sinus rhythm. That proves that tachycardia was the AV nodal dependent, as because injection adenosine blocks the AV node, blocks the circuit, and terminates the tachycardia circuit and re-establish the sinus rhythm. So this is one of the way how we can differentiate between the wide complex tachycardia and SVT and VT. And adenosine is a very short-acting, ultra short-acting drug. There is almost no contraindication for diagnostic purpose in using in case of the wide complex tachycardia, except some specific contraindications are present. So this is one of the examples. So 12-lead ECG evaluation, not only this, if the patient has got the previous ECG, patient has got the previous documents of the ECG, that again helps to differentiate between what kind of the tachyarrhythmia may be. So previous ECG evaluation can find that is whether the patient has got the evidence of the old MI or long QT, or the resting ECG has got the PVC. So this helps, that is these are the possibilities that the patient may have got the ventricular tachycardia. Or if the patient, baseline patient has got baseline pre-excitation or pre-existing bundle branch block, then the patient has got the chances of development of the supraventricular tachycardia. So evaluation of the past documents, particularly ECG, again has got importance for differentiating between the supraventricular tachycardia and the ventricular tachycardia. So not only these kinds of the clue, there are some algorithm for differentiating between the supraventricular tachycardia and ventricular tachycardia. This is one of the algorithm on the left side, that is called the Brugada algorithm. I think all the participants, distinguished participants who are listening this program, you know about the Brugada algorithm. This is the structured ways how to evaluate the Brugada algorithm. And there is another emerging and gradually getting popularity, that is called the Ecg algorithm. That is only depends on the AVR, only one lead. The Ecg algorithm is only class that is that only depends on the only one lead, that is the AVR. That is in AVR. If AVR is positive, that is the VT, that is 98.6% possibilities. Or the AVR is negative, there is a less chance. So if AVR is positive, we can take this that is information from this Ventricular algorithm. This is an important clue that if the AVR is positive in a wide complex tachycardia, this is VT as for example the Ventricular algorithm. Let us forget the other parts. Let us take only one part. That is AVR is positive. It is likely that is 98% chances it is a VT as for example Ventricular algorithm. And this is the Brugada algorithm. The Brugada algorithm is very simple as because we just see whether the QRS complex has got the concordance or concordance, that is either negative or positive. If there is concordance, either totally positive or totally negative, it is VT. But if there is no totally positive or negative, that is no concordance, RS pattern is present, then we have to take help some other, that is the other measurement. These are the other measurement. But what the information I want to give, that is, it is very much clumsy, it is very much difficult, and it is very much difficult to practice all the points, keep in memory in practical life. If one can do, it is better. But one who cannot keep all the points in memory, they can take the help of a summary. And this is the summary. That is, this is the summary. This is the combinations of both the algorithm, that is the Ventricular algorithm and the Brugada algorithm. We have to think only few points. Then most of the time, not the 100% cases, most of the cases we can classify what kinds of the wide complex it may be. That is one point. This is the point from that is the step one. That is from the Ventricular algorithm. That is, if AVR is positive, then is the wide complex tachycardia AVR is positive. This point is from the Ventricular algorithm, 98.6% specificity, that is the VT. But then if Ventricular algorithm fails, then we go to the Brugada algorithm. The Brugada algorithm, it is very much easy. That is positive concordance, VT, negative concordance, VT. These 3 points will help most of the diagnosis of the 98% of the cases. Rest of the cases, we take the other points, like when there will be no concordance, that is RS pattern in precordial lead. That is no concordance, RS pattern. Any of the leads has got the RS pattern. So then at this time, we have to take the help of other points. What is that? No concordance plus monophasic QRS in V1. Again, it is VT. No concordance plus triphasic V1 or typical LBB or typical RBB, that is the VT. So this is the combination of the two algorithms. This is the summary of the two algorithms. And these two algorithms, it is very easy to keep in mind. And this will help to diagnose more than 98% of the cases of the wide complex tachycardia, whether it is VT or VT. If we want to keep memory, both the algorithm, that is this algorithm, Brugada and the Ventricular separately, no problem. You can keep it and practice it. But if you feel difficulty, you can keep just these 4 points in mind. This will help to differentiate most of the wide complex tachycardia, what is the rhythm may be. And some of the example, some of the points that is not mentioned have in the algorithm, but very much important. One who practice the cardiology, we should know some of these points also, as because these are rare, but very much specific. As for example, that is presence of the capsar beat in case of the wide complex tachycardia, like the fusion beat, capsar beat, and evidence of the dissociation. That is evidence of the dissociation present in 30% of the cases. Some of us very much confused to diagnose the that is AV dissociation, feels difficulty for identification of the POF or feels some confusion. So there is no problem. But some of the points, it is nothing to confusion. This is one of the complex. This is one of the complex. These are not like other complexes. There is not like the tachy complexes. These are the tachy complexes, But what is this? What is this? These are some other complexes. Either it is the fused complex or it is a capsar beat. So presence of the fusion beat or the capsar beat in a regular wide complex tachycardia is again 100% confirmatory for the diagnosis of the ventricular tachycardia. So beyond the algorithm, we have to keep in mind, we have to see some other points as well. So this is another example. There is the application of both the algorithm. This is the negative concordance. You see, from V1 to V6, all the QRS complexes are negative. So this is the negative complexes. So I am sure this is the VT. And again, this patient has got the positive AVR. So both the algorithm fulfills, both the criteria fulfills. That is positive AVR and negative concordance. So this white complex tachycardia does not. It needs no confirmation. This is VT sure. And again, we have to see both the algorithm. You see, the AVR is negative. So I don't have any help from the Veric algorithm. AVR is negative. So, but the QRS complex is wide. The QRS complex is very, very wide. So what it can be? So as for example, the Veric criteria does not say it. The Veric algorithm does not tell that this is the SVT, but Veric algorithm does not confirm that is a BT. But the other criteria, that is positive concordance. See, all these concordances are positive. So white complex tachycardia, positive concordance, all the precordial leads again verifies the #1 criteria of the Brugada criteria, Brugada algorithm. So it is nearly 99% specific that this is the VT. So although Veric criteria fails, so it is not true that both the criteria will always be present. We have to think about the possibilities. So one criteria may be absent. So we can help that we can summarize that, take the help from both the criteria. Again, this is another example, that is V1. V1 is positive, AVR is positive, not so wide, RB morphology. So what are the criteria it fulfills? That is monophasic QRS in V1 fulfills. That is Brugger, that is the morphologic criteria. Then it is AVR criteria also fulfills. So that is monophasic QRS in V1 and positive AVR, moderately wide QRS tachycardia. This should be VT. Again, this should be VT. And this is another examples of the white complex tachycardia. But what is the funny thing we see? These are the white complex tachycardia. These are irregular. What is the irregularity? You please just keep in mind the irregularity most in the amplitude. Their QRS amplitudes are not equal. Some of the QRSs are small. Some of the QRSs are big. So this is the region. This is the region, what we call the twisting of the QRS along an axis. So this is the twisting, and particularly this twisting is because of the twisting of that is the variation of their amplitude, variation of the heights of the QRS complexes. This is called the twisting of the QRS complexes. This is called the polymorphic VT. And this polymorphic VT, if we see in one thing, in a case of the polymorphic VT, that is this thing, that is polymorphic VT, transformation into sinus rhythm, that happens spontaneously. That is 100% specific for the torsades pointis. That is torsades pointis, you know, what we've seen, torsades pointis patient, most of the time they develop VF, again back to without any intervention. That is, they have got a less chance to, that is degeneration again into the, regeneration again into the sinus rhythm. This is the some specific peculiarity of the torsades pointis. So this is the torsades pointis. That is what we mean by the twisting, what I mean. And two things, that is twisting of that is the variation of the amplitude, and regaining of the sinus rhythm spontaneously is the confirmation for the torsades pointis. So this is the torsades pointis. And pre-excited tachycardia. This is another example of the white complex tachycardia, irregular tachycardia. By definition, we can say this is the polymorphic tachycardia. But again, this is not the tachycardia as a whole. By definition, it is tachycardia because ventricular rate. What is the definition we applied? If we apply the definition, it is the ventricular rate that fulfills the definition of the ventricular tachycardia. So it is the polymorphic ventricular tachycardia by definition. But interesting is that these are the conducted rhythm. These are the conducted beats from the atrium that creates the ventricular rate. So this is the ventricular tachycardia due to the WPW, that is accessory pathway, that is accessory pathway to atrial fibrillation. So what is the important point from here? This atrial fibrillation, that is white complex tachycardia, if irregular, in contrast to the torsades pointis, here, most important point is that, again, here, the duration is more important. Here, the duration of the QRS complexes. You see the duration of the QRS complexes. This duration wide, this duration moderately wide, the duration narrow, again wide, moderately wide, 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 wide. So what is seen? The variation of amplitude is more important in torsades, and variation in duration plus variation in amplitude, both important in the pre-excited tachycardia atrial fibrillation. So these are the two important things we have to see, and this tachycardia does not transfer into the sinus rhythm spontaneously unless there is intervention. So these are the three points by which we can differentiate with the more polymorphic tachycardia from the pre-excited tachycardia from the torsades spontis. So this is an example of the pre-excited tachycardia, the atrial fibrillation. So what are the tests? So this is about the differential diagnosis. There are some more other points for differential diagnosis of the wide complex tachycardia that needs another classes, but this is something about the some points how to differentiate between the wide complex tachycardia, particularly the ventricular tachycardia and the supraventricular tachycardia, but not the ECG. For the patients of the ventricular tachycardia, for evaluation that needs other test that determines most of the time the management of the patient and outcome of the patient, and these are the tests. That is the ECG. Other than the ECG, echo is very, very important, as because echo, the most important point, echo determines is there any structural abnormality, whether the patient has got the mitral regurgitation, significant mitral regurgitation, or the aneurysm like this, or the non-cooptations, or the hypertrophic cardiomyopathy like this. So echo is crucially important. Two things, that is structural abnormality of the heart and the LV function. You know, LV function independently, single point who determines the outcomes of the VT patient. So it is the echo crucially important. If we other than the ECG do the only single test, that is the echocardiogram, and we have to see the LV function as well as the structural conditions of the heart that determines the prognosis and the management of the patient. So this is the Holter, and by the Holter we can see the prevalence of the non-sustained VT as well as the sustained VT sometimes. So Holter has got again some importance point for the differentiate of the patient, and again sometimes the patients of the VT may have some extra burden, like the patient may have the other abnormalities, like this patient have got the atrial fibrillation or the PVC burden. So it is not only the ventricular tachycardia itself, this ventricular tachycardia may be associated with some other abnormalities, and these are the Holter test can define these kinds of the abnormalities as a whole. Loop recorder, this can be used for a patient who has got the history of the syncope, but there is no documentation. ETT is particularly evaluation of the coronary artery disease, but again, it is again important for evaluation of the hypertrophic cardiomyopathy patient for showing their blood pressure response. A patient of the hypertrophic cardiomyopathy, if shows the hypotensive response during the ETT, that is an important clue for stratification of the HCM patient. So this is the importance of the ECG. And angiogram, definitely coronary artery disease status, as I have seen in 80% of the cases, it is the coronary artery disease, it is the myocardial infarction that is the cause for the ventricular tachycardia, and we must know about the coronary status. That is again important for the management of the patient and for the decision of the patient and risk stratification. And sometimes electrophysiological study is also needed, that is to see the whether the patient has got the some other conditions. So these are the some indication of the electrophysiological studies. It has got the 2A, there is no class 1 indication, class 2A indication, particularly in case of the ICM, NICM or congenital heart disease, who has got the syncope or the syncope suggestive of VT, but there is no documentation. So these are the areas where electrophysiological studies should be done for stratification of the evaluation of the patient. So these are the tests that is needed. I have not gone through details about the test, but these are the tests that is needed for the proper evaluation of the VT patients. So about the treatment strategy of the VT patient. These are the some treatment options. There are 4 options, that is drugs, surgery, ablation, and device implantation. So these are the 4 ablation, that is the 4 options for the treatment of the VT patient. And these are the options of the VT patient management as per settings, as per presentation, as per in case of the acute setting. If the patient is hemodynamically unstable, the patient may need the DC cardioversion or if the patient is hemodynamically stable, the patient may be converted by some drugs like the amiodarone. So these are the setting, that is the treatment as per the setting, that is the presentation, whether the patient is hemodynamically stable or unstable. And these are the treatment option. You are interested to know about the long-term management. So what is the long-term management? The long-term management is two. I say that is three. That is the drugs, ablation, or the device. All these three. These four are the options for the long-term management. So I'm just comparing, not going details about the options. I'm comparing these options. That is the drug option, device option, and the ablation option. These three are the options for the treatment of the long-term management of the patients with the VT. These are the drugs, anti-arrhythmic drug and non-anti-arrhythmic drug. Both groups of drug has got some important role for the management of the, that is the ventricular tachycardia patients. And these are the example of the devices, ICD, CRT, late ventricular assist device, or wearable devices, cardioversion devices that can be used for the treatment of the ventricular ablation patient, that is the ventricular tachycardia patient. And these are the ablation procedure. The ablation may be either primary in case of the structurally normal heart, or extensive in case of the patient who has got the ICD, particularly who has got the ICD, that is even after ICD, the patient has got the huge burden of the ventricular tachycardia. So they may need the adjunctive ablation. So these are the four options. But finally, after all, as because most of the time, it is the coronary artery disease that is responsible for the 80% causes of the ventricular tachycardia, we must not forget the importance of the coronary revasculation. If there is indication without doing coronary revasculation, if there is indication, none of the option will be successful. So we must keep in mind that after all, this should be the final target. That is, we must establish the vascularizations of the myocardium successfully as far as possible. So these are the options. So how does the drug works actually? What is the role of the antiarrhythmic drug? As for example, we have said that is the, for the basic pathology of the ventricular tachycardia, there is substrate and the triggers. The triggers, we can do something for the triggers, but it is the drugs that can modify the substrate. That is the permanent problem of the heart. So here is the beauty of the drugs. There is the role of the drugs. There is the importance of the drug. We always think a patient has got the VT, put ICD, the patient will be okay. No, this is not. This is the wrong conception. The patient needs the substrate modification as far as possible. How we can do? So this is the substrate. We must do something for the substrate, and most of the drugs works at the substrate level, and some of the drugs works at the triggers level. So these are the basic movement, that is mechanism of the heart, that is the drugs. As for example, the drugs also can modify this. This is the same as, for example, the previous slide. So the indications of the antiarrhythmic drugs. So that is the basic mechanism of philosophy, and the indication of the antiarrhythmic drug, particularly in the acute setting. This is the best option, or this is the most commonly used option. That is antiarrhythmic drug, either the amiodarone or some other drugs what to use during the acute setting. That is the very important. So acute setting are sometimes the antiarrhythmic drugs are also indicated. The patient has got the VT, but the patient cannot receive the ICD some other reasons. So there is again the role of the antiarrhythmic drug. And again, the ICD patient who develops the VT, even after ICD, the patient is getting frequent shock. So there is also again the indication of the ICD antiarrhythmic drug. So these are the mechanism for the antiarrhythmic drug. What I told, that is the antiarrhythmic drug can work either at the substrate level or at the trigger level. At the substrate level, they modify the substrate, but at the trigger level, either they can work at the level of the depolarization or at the level of the depolarization. I will not discuss each of the drugs separately. That will take the longer time. As for example, I am giving some examples of the common drugs. This is the beta blocker that can prevent remodeling. So this is the work at the substrate level. and again they can inhibit, that is the shorted, that is the ion channel, that is the anti-sympathetic, so can prevent the automaticity, so they can work at the trigger level. So beta blocker is a good drug as because it can work both at the substrate level as well as the work level. Again, this is the amiodarone. It can work only at the trigger level. It does not have any role at the substrate level. So what at the trigger level, it has got the wide range of activities. So this is the mechanism of action of the amiodarone. This is the action of the sotalol. It can work at the triggers level, but at the substrate level, it can increase the congestive heart failure. Then, and this drug again can be pro-arrhythmic as because it can increase the repolarization time. Potassium inhibitor, as it is potassium inhibitor, it can widen the repolarization time, widen the QT interval, widen the relative refractory period, and this is the pro-arrhythmic effect of the sotalol. And again, the magnesium, it does not have the substrate level, but it can work at the triggers level, and it can reduce the automaticity, enhanced automaticity. So these are the basic mechanism of the antiarrhythmic drug, and sometimes we use the combination of the drug, that is mexiletine plus the amiodarone, or amiodarone plus the sotalol, or beta blocker plus amiodarone, or ranolazine plus other drugs. So there are some specific indications for using the antiarrhythmic drug in combination, but antiarrhythmic drug are not can do all the effects what we want in case of the ventricular tachycardia patients. I will discuss later on. And there is some indications of the catheter ablation. And particularly, this is indicated in case of the idiopathic VT, that is idiopathic late ventricular VT or the outflow tract VT, or in case of the post-ICD, that is the patient who has got the ICD but he still has got the VT. This group of the patient needs the ablation. This is one of the example of the wide complex tachycardia, LVB morphology. So this is RVOT VT. These are the calcium dependent. So medically can be managed by the verapamil or the diltiazem, but can be curable, that is curable by the ablation. Most of the time successful ablation can be done in these groups of the patient. That is one of the example of the catheter ablation where you do, that is RVOT VT. And this is another example of the tachycardia. This is moderately wide, RBB morphology, left axis deviation. This is classic example of the ILVT, idiopathic late ventricular tachycardia, or someone called vesicular VT. This is not an uncommon problem. This is a common problem. This happens in case of structurally normal heart, but not absolutely normal, as because this is a re-entry between the conduction system. That is the this is the moving heart. You see, there are some. This is the late bundle branch, and there will be some fascicles of the late bundle branch. So there will be re-entry between the fascicles, anterior fascicle, posterior fascicle. So re-entry is the basic cause, and if we ablate the re-entry circuit, then this tachycardia will be cured. So this is the ILVT. This is the classic example. So these are the three areas, that is the RVOT VT, ILVT, and VT in ICD patient that needs the treatment by the ablation. But not always the VT ends with the ablation. For the VT stratification, there are some other areas that we must also address. This is the scope, that is the algorithm for evaluating the patients of the ventricular tachycardia, particularly that is the LV function. That is the LV function of the VT patient is more important. As for example, LV function is the single most predictor or determinant of the outcome of the patient, single most. There is no other comparable parameter like the LV function who can determine, who can tell the prognosis of the VT cases. So this is the single most important factors for determining the outcome of the VT patient. And for this, depending on this criteria, some of the patient may need this device. This is the ICD, that is the emergency chamber within the heart. This ICD cannot prevent the occurrence of the VT, but it can decade the VT. And if there is VT, it can terminate by that is shock. So this is the device. This is the ICD, or sometimes it can be CRTD that is needed in some patients of the VT, and that criteria again guided by the LV function. And this is the some of the examples. That is the sum of the big trials. That is the sum of the secondary prevention trial and primary prevention trial. And we can see from 31 to 60% of mortality reduction by the devices in comparison to the drugs. That is, drug has got either no role, or sometimes can increase the mortality in case of the VT patient. But it is the drug that has been proved that needs no further clarification by the primary and secondary prevention trial, that the ICD can prevent the mortality of the sudden cardiac death in the VT patient. And the benefit is that the prevention of the mortality rate is nearly 31 to 60%, depending on the various studies from the mass study or the MEDIT studies. So this is the indication of the drug, and these are the different trials, that is MEDIT, MAST, and the SCA heart failure trial, and these are the percentage of mortality reduction by using the drugs in comparison with the antiarrhythmic drugs. So ICD indication. So ICD indication, very simple to mind. In case of the ischemic cardiomyopathy, there is LV function less than 40% plus VT, or if the LV function is less than 30%, then it should be NYSA class 2, or if LV function less than 30%, then NYSA class 3. So we can keep it in mind. Less than 30%, NYSA class 1, 35%, NYSA class 2, less than 40%, that is better LV function, then less than VT or VF in case of the ICM. And in case of the non-ischemic cardiomyopathy, in case of the ACM or ARVD, there are some specific criteria for indication of the VT. And these are the channelopathy. They have got also some criteria for indication of the VT, that is ICD. So ICM, non-ischemic cardiomyopathy, or the channelopathy, or the that is the genetic diseases, that VT can be treated by the ICD. So the ICD, that is sudden cardiac death incidence, ICM 75%, non-ICM 15%, and genetic diseases 10%. So as this at the range of the frequency of the risk of the that is sudden cardiac death, and this is the region, these groups of the patient need the treatment with the ICD for the prevention of the sudden cardiac death. And that prevention of the sudden cardiac death either may be primary, that is the patient who does not have previous cardiac arrest, or secondary, in patient who has experienced the previous syncope or the cardiac arrest. So the objectives of the Icd implantation either may be primary or prevention of the sudden cardiac death, not the prevention of the occurrence of the VT. That is the basic conception we have to keep in mind. So ICD benefits: overall mortality reduction more than 30%, and absolute mortality reduction 10 to 20%. That is the good, very much useful benefit. But ICD still have some limitation, that ICD do not prevent the recurrence of the VT and do not change the anatomic substrate. It can only treat the VT, does not change the anatomic substrate. And for that reason, we need the antiarrhythmic drugs. As antiarrhythmic, not that all the drugs, that is the anti-failure drugs. That's in combination with the ICD. It is the anti-failure drugs that can modify the substrate, that can reduce the incidence or reduce the recurrence of the VT. That is more important. And that is the combination of the two things that can be used for the treatment of the patient. It is not the ICD. We implant the ICD and it is all the things. So this is not, this is the basic concept. We have to do everything. So antiarrhythmic drug is definitely inferior to ICD for the, if the mortality reduction is concerned. Again, some of the drugs may be pro-arrhythmic. So this is the reason antiarrhythmic drug is not as an absolute agent for that can be used for the reduction of the sudden cardiac death. And there is some other markers in other diseases that can be used for the indication of the sudden cardiac death, that I have already told. And this is the rhythm that we don't want to see. That is the rhythm that we want to see, as because this is the final rhythm. What we mean, these are the rhythm that is originated from the ventricle. These are chaotic, bizarre. This is the ventricular fibrillation. And if this patient has got ventricular fibrillation, either as a primary or degenerated from the ventricular tachycardia, the patient has got only 9 minutes in hand. Either he will survive or he will die. This is a very fatal disease. We don't want to see, but still you have to treat. Nothing is over until it is all over. So we have to see the patient, we have to treat the patient, we have to treat the malignant diseases like the ventricular tachycardia. Thank you very much. Thank you, everybody.
Atahar bhai, thank you. Extensive, beautiful lecture. Dear audience, I hope you have enjoyed the whole lecture.
Sir, what an excellent lecture, sir. I am so much confident. So much confident.
Well presented and very easy, palatable lecture, I would say. And I hope the audience has...
Now, how much confidence about the subject, sir? It is important, sir. Yes, sir.
Mohsin, তুমি আমাদের প্যানেলিস্টের একটু কমেন্ট নাও।
প্যানেলিস্টে স্যার আমার মনে হয় স্যার সাবজেক্টটা একটু জুনিয়রদেরকে আমরা কথা বলতে দিই, কারণ একটু ওদের জন্য একটু কঠিন বলে আমি জুনিয়রদের সুযোগ দিই স্যার আগে। আচ্ছা, হ্যাঁ, তারপর আমরা ওদের প্যানেলিস্টে যাই স্যার। আমার নজরুল স্যার আছেন এখানে না? অবশ্যই নজরুল স্যার আছেন স্যার।
নজরুল স্যার আছেন।
আমার নজরুল স্যারকে ডাকি স্যার।
প্রফেসর নজরুল স্যার আছেন?
হ্যাঁ স্যার, শুনছেন স্যার?
স্যার
স্যার
দেখছি না। জালা স্যার আছেন?
জালা স্যার আছেন?
জালা স্যার আছেন?
সবাই মিউট করে রাখছেন।
হ্যাঁ, অরুণ আছে, অরুণ মাস্কি আছে।
হ্যাঁ, এটা অরুণ মাস্কি।
Arun, can you unmute?
Yeah, I'm unmuted.
Yeah.
Yes. Hello, Arun. How are you?
Yeah, hi.
Did you enjoy it? The lecture?
Yeah, this arrhythmia is a topic which is very big headache to me, in fact. So he has presented in such a nice way, and Atahar has made this presentation very simple, elaborate. So thank you, Atahar. It was an excellent presentation.
Welcome, Maski.
So, yeah, Atahar, your presentation, as usual, is very nice. So you have presented in such a simplified way. One problem with us is arrhythmias are a big headache for us. So you have presented in such a nice, simplified way. Thank you for your excellent presentation, Atahar. It's always good to listen to you.
Welcome, Maski. I'm happy to see you.
Dr. Shudhir, do you ask any question?
Yes, sir. Assalamu alaikum, sir. Sir, can I Bangla কিছু বলবো? One of the smartest person I have ever met. উনি একজন, এবং উনার কনফিডেন্স লেভেল দেখে আমি সবসময় ভয় পাই, যে এত কনফিডেন্স আর যে কোনো কথা বলেন এত কনফিডেন্টলি যে ভুল হইলেও কিন্তু আমরা মানতে রাজি হই, মানে অন্তর থেকে রাজি হই। আমি স্যারকে এত ব্রিলিয়েন্ট প্রেজেন্টেশনের জন্য আমি খুবই মন থেকে ধন্যবাদ দিই, এবং আমি স্যারের কাছে একটা রিকোয়েস্ট করব যে স্যার মেডিকেল ট্রিটমেন্ট আপনি একটু খুবই র্যাপিডলি গেছেন, ওইখানে আপনি স্কিপ করার চেষ্টা করেছেন। পরবর্তীতে যদি সম্ভব হয় স্যার আমাদের জন্য মেডিকেল ট্রিটমেন্টটা একটু স্যার ডিটেল একটা প্রেজেন্টেশন আমি চাই স্যার। আই হ্যাভ সাম অফ কনফিউশনস, আমি যেটা আমি আপনার কাছে রাখবো। দি ফার্স্ট ওয়ান ইজ, ইন সাম অফ দি স্লাইডস ইউ হ্যাভ শোন accelerated idioventricular rhythm, আমরা বলবো if the heart rate is between 60 to 100, but again you are saying that the guidelines is saying the heart rate should be between 100 to 120. My question is, if the heart rate is between 100 to 120, why we are not calling it tachycardia, ventricular tachycardia, and why AIDR? This is my first question. Second question is that you have mentioned that in some of the cases, though it's rare, in ventricular tachycardia, the complexes can be narrow. But from our general knowledge, we know that when an ectopic focus is taking, it's arising from ventricle muscle myocardium, the transmission will not be normal. The transmission will not be through the normal conducting pathway, and it will be from cell to cell transmission. And in that case, the complex will be wide. So why it is narrow? Explanation of this. Third question is, sir, my question is, it is important to differentiate a polymorphic VT, because we know that there are different forms of polymorphic VT from torsades depointes, because the treatment is different. And most of the time, what we clinicians do is, just by seeing the morphology, we tell it that this is torsades depointes. But it's not always true, since the treatment is different. And so it's saying that it should always be distinguished, both should be distinguished from one another by calculating the QT interval. But my question is that it is that easy to calculate QT interval by seeing VT. Okay. And what is the difference between bidirectional VT and polymorphic? Sir.
Hello, Chowdhury.
Hello.
Sir, unmute. Okay, sir.
Hello.
Pauline, sir.
Thank you very much for 3 questions, and I will welcome our other faculties. I can see our Professor Mohsin, Professor Abdul, and Professor Mohsin Ahmed also. They can also take part in the discussion of the 3 questions. I can answer, but they are all, I am also welcoming everybody to take part discussion of the answer of this question. Yes. From first of all, I want to take give some ideas about that. That is about the rate. You have told that is absolutely true, Sudhir. That is a rate is an important factor. Atahar guidelines 2019 that describes, that is the rate. That is, they have described the VT 100, that is a more than 100 per rate. But in other guidelines, that is 120. And they have told that is 100 to 120 is accelerated idioventricular rhythm, and less than 20 is the idioventricular rhythm. That is the idioventricular, that is less than 100. That is the less than 100 idioventricular rhythm, 100 to 120 accelerated idioventricular rhythm, or more than 120 ventricular tachycardia. But that guideline, 2019, ACC Ahar, they have described straight away that is rate 100 or more is the that is the ventricular tachycardia. And in that guideline, possibly I have not seen the term accelerated idioventricular rhythm. Possibly they have omitted this term. So I will request some of the faculties, particularly Professor Mohsin, you can take part for answering this question. But Mohsin
Hussain bhai, do you hear? Professor Mohsin Hussain, please unmute.
Unmute, sir.
Okay. Unmute হয়েছে, Mohsin bhai বলেন।
শোনা যাচ্ছে?
হ্যাঁ, শোনা যাচ্ছে, শোনা যাচ্ছে।
স্যার যেটা বলতে ঠিকই বলছেন, this is the right, this is the, by definition, if the rate is more than 100, yeah, and this is the right. But in case of idioventricular rhythm, it is one kind of ventricular tachycardia. So the ACCR guideline, new guideline, they have added this new term. If the rate is more than 100 per minute, it is ventricular tachycardia. So idioventricular rhythm is one kind of ventricular tachycardia.
Wadud bhai,
মিস করলাম, আমাকে আবার যেটা হয় আর কি
rate of the
মানে VT, মানে that is the definition of the VT by that is the number of the beats as per guidelines. Accelerated idioventricular rhythm, that is there 3 terms: idioventricular rhythm, accelerated idioventricular rhythm, and the ventricular tachycardia. The recent guidelines straightway defines that the ventricular tachycardia is defined 3 or more complexes, consecutive complexes in a series at the rate of 100 beats per minute or more. That is the ventricular tachycardia. So that is actually the term that was asked by the Dr. Sudhir, and that was what described that is the. So do you want to have any comments? Wadud bhai?
Actually, idioventricular rhythm is a ventricular rhythm, but it's not in the range of VT, and by nature is not that harmful as VT, and also it indicates particular setting, particular background. That's why this has been separated from actual VT.
next second question, sir. Is okay, sir? Right, it is okay.
Before that, Dr. Sudhir, can you hear me? Hello?
Yes, sir. Yes, sir.
Sudhir,
Yes, sir. I can hear you.
Acha. So I will not discuss, but I am giving you a clue. That is a idioventricular rhythm or accelerated idioventricular rhythm. Sometimes maybe one of the escape rhythm. That is not the VT. That is the life-saving rhythm. What we see in case of the complete heart block. There is a ventricular rhythm in case of the complete heart block. That is the escape rhythm. Will you say that is the VT? That is the complete heart block ventricular rhythm, is that there is the 60 100. Will you say it is the idioventricular rhythm? That is the escape rhythm. So I will not discuss today. That is the area. That is how we can differentiate. That is the escape rhythm. There is some points how we can differentiate with the escape rhythm of the ventricular tachycardia. Ventricular tachycardia should have some originated from some specific mechanism. That is either automaticity, reentry, or triggered mechanism. And yes. So escape rhythm and idioventricular rhythm is something different. And so this is the points. Sudhir, am I clear to you?
Yes, sir. Very clear, sir.
Okay.
Second question, sir.
Second question about the duration. That is the interval. That is a narrow complex. Yes, that is mechanism. As because if the that is a conduct, that is a depolarization of the ventricle. If the depolarization of the ventricle uses the normal conduction system, his Parkinson system, as for example the supraventricular tachycardia. The supraventricular tachycardia comes and the ventricular depolarization happens by the normal QRS, that is the conduction system. It has got the normal physiological pattern. So this is the QRS pattern is the physiological pattern. But in case of the arrhythmia, when it originates from other than the normal conduction system, so there will be the duration. So the duration of the QRS complex depends upon two things: from where the complex is originated and how far from the complex is coming from. As for example, its complex is coming from far away from the normal conduction system, that is the septum, as far as for the epicardium, and it is taking longer time. So there will be wide QRS duration. But if it takes the very close to the septum, very close to the normal conduction system, as it happens in case of the fascicular VT, this fascicular VT is taking part. That is some parts of the conduction system that is re-entry within the conduction system. So it quickly enters into the conduction system. So it is taking the less time. So it is moderately wide. This is not neither normal nor very wide. It is moderately wide. So this is the reason, that is anatomically which part is taking for the development of the tachycardia, and from which area, from how far area the tachycardia is coming to the conduction system. This is the two things that determines the duration of the QRS complexes. Am I clear, Sudhir?
So, if there is a ventricular tachycardia associated with pacemaker dysfunction, what do we expect? Should we expect a very wide complex QRS tachycardia?
Yes, Wadud.
Isn't it?
Yeah, sure.
In that case, that QRS complex is very wide.
Right.
Again, if there is diffuse cardiac muscle damage, as for example, advanced cardiomyopathy, DCM, most of the VTs arising from there, will it be wide?
Wide, and depending upon the wide, you can predict how much severity the disease is. QRS duration 140, QRS duration 160, QRS duration 180 means something.
Yeah.
That is
very bad.
More and more time. Disease is more and more progressive. That the conduct system more and more sick. That disease is more and more diffuse. So this is the time that is taken by the conduction system to come to the normal conduction system. And what is truly spoken, that is the.
And that's why in CRTD, if the QRS complex is more than 160, around 180 or more, the success of CRTD is low, isn't it? Exactly. It indicates extensive myocardial damage.
Myocardial damage, right? True.
Do you understand? I hope the audience understands, because very wide QRS complex actually predicts putting an ICD or a CRTD is not going to help the patient much. The patient needs cardiac transplantation perhaps. And here, the echo is the main factor that will determine which way we should go.
Sir, third question, sir. Differentiation between torsades and other polymorphic VT, as because other polymorphic VT may also be confused as torsades dyspointes. And the guideline says that they should always be distinguished by the help of the QT interval. But what do you suggest, sir? Arekta question, sir. What is the difference between bidirectional VT and polymorphic VT?
Acha, torsades pointis. Torsades pointis is a polymorphic VT from the ECG. If you can see the long QT, it is good, but you may not see the long QT all the time. That is, if it is only the VT, that is, the tracing has got only the VT. There is no QT interval. No, there is no sinus. For the QT interval, you need the sinus rhythm first. So there are few points. That is, if you can see the QT interval, and grossly the QT interval is more than RR, that is 50% of the RR interval, you don't need PR. If more than RR interval, that is the criteria, then it is the long QT interval. So whether it is present or not, just see the tachycardia. Whether the tachycardia is, that is very much important. Whether the tachycardia is irregular, particularly because of the amplitude of the QRS duration. If the amplitude of the QRS duration is variable, that creates the twisting nature. This is called that is called the twisting nature. That is variation of the amplitude of the QRS duration is the most important factor for the differentiation of the polymorphic VT. And if you see again the termination in the sinus rhythm, if the polymorphic VT has got self-termination into the sinus rhythm, and if you can document in the single ECG, that is confirmatory, that is the torsades pointis. So these are the few points for the regarding of the torsades pointis. And from differentiate from the other polymorphic VT, particularly important is the particularly atrial fibrillation in the accessory pathway. Here I have told already that you can see the clue. That is the patient, if you can lucky to see there is a sinus rhythm and you can see the QRS duration, sliding of the QRS complex, that is a clue. That is this may be that pre-excitation. You may see, you may not see. But if the QRS duration has got variation in the duration, that is wide of the QRS complex will be very variable. Some QRS complex narrow, depending on the conduction. Some is conducting very faster, that is narrow. Moderately faster, wide. Slow, that is more wide. So depending on the conduction, QRS duration will be variable. So variable both in duration and amplitude is the hallmark for diagnosis of the pre-excited ventricular fibrillation. And only the duration, amplitude is the torsades pointis. Am I clear, Sudhir?
Very clear, sir. Bidirectional VT and polymorphic, sir, ekটু বলে দেন।
Acha, I am requesting Professor Mohsin to answer this question. Mohsin.
Mohsin?
Bidirectional polymorphic. I have seen you answer this question several times. So you please.
Sir,
yeah.
Irregularly, WBW pre-excited studies telling the QRS is wide and some narrow, because when the impulse goes to the normal QRS complex, that is AB node, then it becomes narrow. When the impulse goes to the accessory pathway, it pre-excites the ventricle, so it is wide. So sometimes wide, sometimes narrow, and as it is atrial fibrillation, it will be regular. And bidirectional VT, mainly it is very uncommon. Some there is the one complex is upwards, one complex is downwards. So most likely it is seen in the dioxin toxicity and sometime in the CPVT, that is the catecholaminergic polymorphic ventricular tachycardia.
Actually, torsa is actually a bidirectional VT, but in a misnomer. Right. Because in a bidirectional, actually we include two different types, catecholaminergic and deoxyniacetic VTs. These names are more important for the prevention and the approach to the patient, which way you should go. For deoxyniacetic tachycardia, what will be the protective drug? For example, in torsa, withdrawal of the offending agent, giving IV magnesium, or raising the heart rate. These three approaches can very nicely work. But what about catecholaminergic VT? Which way should we go? And what about deoxyniacetic VT? What treatment approach you are going to take? Atahar bhai?
Sorry?
আপনি ডিগক্সিনঅ্যাসিটেট যে ভিটি গুলো সেগুলো আমি অ্যাপ্রোচ কি নিব আর ক্যাটেকোলিমার্জিক যেটা আমার আছে ভিটি আছে সেটার জন্য আমার অ্যাপ্রোচ কোনটা হবে কারণ টর্সার ট্রিটমেন্ট আমরা জানি ম্যাগনেসিয়াম দিব ইলেক্ট্রোলাইটটা ঠিক করব পটাশিয়ামটা ঠিক করব তা অফেন্ডিক এজেন্টটা উইথড্র করব এবং তার হার্ট রেটটা বাড়াবো কিন্তু ওগুলার কি হবে
সিপিভিটি that is the catecholaminergic VT সেটা আপনি মানে nicely and correctly you have told that is it is the polymorphic VT is sometimes the bidirectional VT, and it is the automaticity, that is enhanced automaticity is the mechanism, and sympathetic system is the responsible for this kinds of the VT. Sutarang, anti-sympathetic, as because it is the automaticity is the mechanism, re-entry is not the mechanism, so there is a less success rate by the ablation. It is automaticity, enhanced automaticity. So drug should be the treatment. Yes, there are some reports where the ablation therapy has been done, but it is not suitable for the ablation as because it is not the re-entry mechanism. So enhanced automaticity is the mechanism. So beta blocker is the treatment. That is the beta blocker is the drug of choice for the beta blocker is the drug of choice for the CPVT, and sometimes depending on the necessity as per indications, ICD may be needed, but drug is the mainstay for the treatment of the CPVT, and the beta blocker is the main drug. That is anti-sympathy, anti-adrenergic drugs in treatment. And for the, sorry?
Can I add something?
Yes, yes, sure.
What about the limitation of the exercise and the yoga therapy, the respiratory therapy that can, by which you can actually control your heart rate?
Thank you very much. One important thing that I have missed actually, but Professor Wadud again stressed this point, and even I put this point for the discussion as far as exercise is an important part for the education of the patient, VT education of the patient, as because there are some of the VTs those are inducible by the exercise, that are induced by the exercise. So suggestion about the exercise is a part of the treatment for the VT management, particularly in this case of the CPVT, and particularly in case of also the that is some genetic conditions like the Brugada, and particularly in case of the that is the some other example also the HCM. So Brugada, HCM, CPVT are the areas, are the candidates. These groups of the patients should be nicely educated about their exercise. As per rule, exercise may be the cause for the VT, and many of the records the patient dies during the exercise, say during the VT and the sudden cardiac death. So exercise should be, so these groups of the patients, the CPVT groups of the patients, they should be well educated about their exercise, that they should not do anything that can increase their sympathetic activity. So
thank you, sir. For the attendees, for the examiners, Dr. Arif, do you read the question put on chat box for the examiners?
Thank you, sir. First, I'd like to thank Atahar sir. This is the thing we always learn and forget and learn. There are lots of questions in the chat box. A few questions already discussed. Even then, they want to hear again. So I'm uttering few questions from the box. Dr. Rehan wanted to know drug of choice in ischemic versus non-ischemic ventricular tachycardia.
Atahar bhai, আমি এখানে একটা কোশ্চেন আমি একটু ঘুরায় বলবো. I will just rephrase it. What should be the approach? Because only drug of choice means only one drug. I don't agree. What should be the approach in managing ischemic VT and non-ischemic VT? That should be the question.
Right.
Answer.
Exactly, sir.
So there are, for the drug management, I have already told, there are two aspects of the drugs. That is one group of the drug that helps to modify the substrate, that is the basic pathology of the heart. And here is the role of the antiarrhythmic drugs. As for example, use of the AC inhibitor, beta blocker, and the ARNI. These are the groups of the drugs. They can modify, remodel the substrate, enhance the substrate, and they can modify the substrate, and then thereby can reduce the occurrence, that is the prevalence of the VT of the patient. So these are the tremendous role. We must not forget the role of these groups of the drugs. That is some of the antiarrhythmic drugs and some of the drugs. And if we want to select the drug for the prevention of the sudden cardiac death, if this is the question, whether we want to select a drug for the prevention of the sudden cardiac death, yes, the answer is straightforward. There is a drug which is superior to ICD for the prevention of cardiac death, if ICD is indicated. So, if ICD is indicated, then it is the ICD that should be. But in some areas, when the patient cannot use the ICD, there is limitation of the ICD, or the patient may have got the VT even after the ICD, whether the ischemic or non-ischemic cardiomyopathy, then the best drug to use is the amiodarone. There are some many limitations of the amiodarone, but still, this is the drug that should be used in case of the amiodarone, and amiodarone can be combined with some of the drugs as per needs. As for example, amiodarone can be combined with the sotalol, amiodarone we can combine with the mexiletine, depending on the situation. But neither of the drugs has got the mortality benefit. But if mortality is concerned, it is the ICD that should be. So there are two drugs, antiarrhythmic drug and non-antiarrhythmic drugs. And non-antiarrhythmic drugs are more important than the antiarrhythmic drugs for the treatment of this patient. Am I clear?
Can I add something?
Yes, Wadud.
Look at this. Previously, we have had beautiful lecture from Professor Nazrul Islam sir about the mortality in heart failure. And 50% of the heart failure patient had sudden cardiac death. That means mostly from arrhythmia. And which drug has the most lowering, mortality lowering effect? Look at the record. ACE inhibitor, first, but beta blocker is superior to ACE inhibitor in reducing mortality. And the track record is best on mineralocorticoid antagonist, spinal lecture or aplanar. And why is that? Both of these, mineral receptor antagonist or aplanar, spironolactone or aplanar, they both increases potassium, increases magnesium. They are acting like a cardiac sedative. Both of them act as prevention of automaticity. They do not have any substrate level activity. They have trigger limiting activity. Spironolactone also had some effect on the modeling by preventing fibrosis and etc. So, considering all these, the answer should be, I do think, in case of ischemic origin, I would go for proper guideline-directed medical treatment and revascularization. And even then, if the EF is not increased, ICD for the short term and amiodarone. For non-ischemic cardiomyopathies, it's again the drugs, they controls the heart failure, improves the ejection fraction is the most important thing. And then, if the ejection fraction is not improved, you have to go for ICD or CRT. In both cases, as indicated, if the Qrs complex is wide, ejection fraction is low.
No. Thank you very much for your summary. That is the answer that I wanted to emphasize. That is actually we always underestimate the role of the anti-failure drug. That is the important point I want to mention. That is why we should not confuse the role of the anti-arrhythmic drug versus the anti-failure drug. What Wadud stressed, that is the anti-failure drug has got clean-cut mortality benefit. Clean-cut mortality, that is the ACE inhibitor, beta blocker, spironolactone, clean-cut mortality benefit. But sudden cardiac death prevention
only
by the drug.
ICD.
This point should be clear. Thank you, please.
Thank you, sir. Dr. Rahat wanted to know, is there any way to differentiate between SBD with aberrancy and with pre-existing band and branch block? SBD with aberrancy and pre-existing band and branch block.
Hello?
Okay. Sir.
Yes, pre-existing band and branch block. Yes, if we know from the previous document that this patient has got already pre-existing band and branch block, this is an additional help, not the important point. This is an additional help. I am already ready. If this patient has got the wide complex tachycardia, almost same as the previous bundle branch block. That is the previous document shows the RBB. Now the wide complex tachycardia is RBB. This is unlikely to be VT. If this patient has got the previous is LBB, the wide complex tachycardia again LBB. This is unlikely to be VT. But if the patient has got the previous RBB, now the wide complex is LBB. There is a discrepancy. This is likely to be VT. So this is one of the important points. That is the document, that is the analysis of the previous is one of the important points. And again, we have to apply for the morphology criteria. That is, we have to see the V1, whether the RBB morphology or the LBB morphology. if the RBB morphology, whatever maybe the previous ECG has, if the VT, that is wide complex tachycardia, if it is the monophasic, it is VT. If it is triphasic, it is SVT. Again, we have to see that that is a V6 criteria. So we have to analyze in this way. That is previous documents plus the V1 and the V6 morphology criteria. Am I clear?
Can I add something? Can I add something?
Sure.
That's why if the patient is hemodynamically stable, you must use adenosine to differentiate whether it is actually true VT or a SVT with aberration.
True.
That's why adenosine is so important.
Sure. This is also diagnostic. We always hesitate. Sometimes we hesitate, but there is nothing to hesitate. This is a very safe drug.
Adenosine is not going to produce any VT or VF or anything.
Dr. Dipal Adhikari, Dr. Dipal da shunchen. Dr. Dipal, do you hear me?
Shunchi.
Please ask a question. Congratulate you and
আমার নেটওয়ার্কে একটু ঝামেলা আছে এজন্য আমি ভিডিওতে যেতে পারছি না আমার কোশ্চেন অলরেডি চ্যাট বক্সে দেওয়া আছে ওগুলো স্যারকে দেখালেই হবে
ask a question please
না সজল চ্যাট বক্সে দেখতে পারবে আমি লিখে দিছি
সজল
বড় বলেন
আচ্ছা আমি সিরিয়ালি যাচ্ছি আমি বলতে যাচ্ছি স্যার আমি আগে তারপরে সে অটোমেটিক চলে আসবে স্যার there is one question by Dr. Harun. He wanted to know why and how Torsades the point is revert to normal sinus rhythm without intervention.
Beautiful question.
So, Mohsin, I think you are
Professor Mohsin.
I think Mohsin is interested to answer this question.
Professor Mohsin, please.
He's laughing. Mohsin, please answer.
Yes, Professor Mohsin.
Mohsin, unmute. Yeah.
Can we repeat the question again, sir?
Sinus rhythm. Torsades point is sinus rhythm. How?
Without any intervention.
Torsades যে spontaneous sinus rhythm এ যায় কেন যায় কিভাবে যায়?
Because the nature of the disease, the torsades point is self-limited. This is a sequence is short, long, then followed by PVC and then initiate and start the basic of the mechanism. So it's self-terminating and then again sinus rhythm. This is the usual nature of the disease, and sometimes it may degenerate to VF, and sometimes patient can do sudden cardiac death. But if the cause is that is the identifiable cause, electrolyte imbalance or something, even withdraw the opening agent, then we can correct the case. Sometimes with the rate by temporary pacemaker or isomeralin. It is just sometimes it needs ICD.
Can I add Wadud?
I'm not yet clear. Can you answer it?
Can I add one point?
Sure, sir.
Actually, initiation and termination of torsades point is. That is the initiation. What the Professor Mohsin already told. That is the before initiation. That is the I have already told. There is a variations of the repolarization. Variation of repolarization time. That is long, short. That is the variation. What does it mean? That is the stable. That is the repolarization time. QT interval is not stable. Some QT is long, some QT is short. This long, short pause is a basic mechanism for development of the torsades point is with a PVC, not without. There is a long, short pause, and the PVC comes that initiates the ventricular. And I have already told, and that is another time that is for the how the tachycardia is regularly irregular. Again, if this tachycardia continues, and if there is a instead of the long, short, some of the complexes are coming short, long, then the tachycardia will be terminated. So this is the basic requirements for this tachycardia to survive. This tachycardia needs always unstable repolarization time, long, short sequence. What you see by the irregular of the torsades point is tachycardia. But if sometimes goes more regular, becomes more regular, short, long, that is long, short sequence is broken, the tachycardia terminates into the sinus. And this is the way, without any intervention, spontaneously this tachycardia can be terminated the sinus. So it is the duration of the repolarization time, it is the duration of the QT interval that determines whether the tachycardia will survive or not.
Excellent explanation, sir. Excellent, sir.
Sir. Professor Jalaluddin, sir.
Yes.
Sir.
Walaikum salam.
Assalamu alaikum, sir.
I am very happy that Professor Atahar discussed ventricular tachycardia in so many ways, how it can happen, what is the mechanism, what is the causes, the treatment. So many things he has discussed. In my time, when I started cardiology practice in 1979 and onwards, at that time, when a patient came to us with palpitation and with tachycardia, we did the ECG. We found whether it is sinus tachycardia, supraventricular tachycardia, or ventricular tachycardia, atrial fibrillation, atrial flutter, like this. Now, the thing has become, that was treatment also was very easy, whatever with the result of the treatment. But now the treatment has become, the mechanism, causes has become so many. Now the treatment has also become so complex, and result is also different. Some are getting better result with the treatment, and some are getting also, few of the patients are getting bad result also with the treatment, either by drugs or by other things, device or surgery, like this. Ablation is sometimes very much acceptable, and sometimes it's not also very much good for all patients. So, Professor Atahar discussed the ventricular tachycardia in so elaborately, and he discussed the mechanisms of origin of ventricular tachycardia so beautifully. And he has, last of all, he has minimized or simplified the treatment, that is drugs, surgery, ICD, or ablation. These are the 4 things by which ventricular tachycardia can be treated. And he has mentioned which should get drugs, which one should get surgery, which one should get ICD, and which one should get ablation. Now the things has become so elaborate. In our time, the ventricular tachycardia was a small topic in the book. Now I think the thing has become so complex and so elaborate. Professor Atahar has discussed. I think the time has come to write a textbook on ventricular tachycardia. So thank you very much, Professor Atahar and other panelists, to discuss the things so widely and very beautifully and very fruitfully. Thank you very much.
Thank you, sir.
Arif, next question.
Sir, Deepak sir asked few questions. One of them question is, in case of bradycardia induced ventricular ectopics, which antiarrhythmic drugs will be feasible? Bradycardia induced ventricular ectopics, which antiarrhythmic drugs will be feasible?
I want to take help from Mohsin, Wadud.
Mohsin?
Brady-induced bleeding.
Any management?
Brady-induced BT may treat the cause. If the underlying cause is fine, then it will automatically disable the PVC. This is the main treatment. Ideally, no drug should be needed. If you correct the underlying treatment, if the patient has bradycardia or complete heart block, patient needs pacemaker, it will then correct the BT. So, the underlying cause is the main reason, sir.
Thank you, sir. Deepak, sir, next question is, sir.
Wait, can I add something?
Sure, yes, sir.
This is particularly important in this era of COVID, because COVID patients sometimes develop carditis, and instead of tachycardia, some of these patients started developing bradycardia, and very often this is a terminal event. And we have some experience in Dhaka Medical College. We have been using anticholinergics, or in case of some patients, we have even used theophylline, a bronchodilator as well as a tachycardia induced drug. And that has helped to stabilize the patients. And most important, in these patients have carditis, some degree of carditis. So we are actually using steroid for the carditis as well. But as Mohsin Hussain was suggesting that treatment of the underlying cause is the most important thing. And I think it's one of the long QT has some sleep time VT, isn't it, Mohsin? Atahar bhai?
Yeah, sure.
And that is associated with bradycardia.
Professor Mishkat Ahmed sir with us. Professor Mishkat, I think your name is Samsad Jahan.
Nah, এটা আমার বান্ধবীর নাম।
Oh, আচ্ছা।
His wife is my batchmate.
আমার ওয়াইফের এটাই ইউজ করি আমি কি কিছু কমেন্ট করতে পারি?
অবশ্যই।
Yes.
My question is how much we should be concerned about the Brugada syndrome, meaning that how rigorously actually we should look at the ECG to find out some Brugada syndrome, because Brugada syndrome in ECG has got different pattern, and we have known a seminar to be attended in the United States years back. The name of the symposium was Brugada Symposium. So as teacher, when I want to share with my student as regard the ventricular tachycardia and the PX exciting syndrome or the causes of syncope, how much emphasis should we give on Brugada syndrome, and how much enthusiastic should we be in finding out some ECG finding of Brugada syndrome?
Thank you, sir.
Thank you very much for your nice question, Moshkat bhai. And I think the Moshkat bhai already knows the answer. And I think if I miss some of the points, I request Moshkat bhai to add these points, as because this is a very important disease, because the most important thing is that this is not so common, again not so rare, but it is important for that patient who has got the Brugada. It's because there is no in between. Either the patient will survive or the patient will have the sudden death. So this is important for so decision making is important for that patient. So this is the reason why the patient. So this is the reason I think the patient has asked this question. There are some specific criteria. That is, we know how to evaluate the Brugada patient, starting from the history, whether he has got the syncope or cardiac arrest, starting from the family history, particularly from the first degree relative, or the patient has got the class 1 type of the Brugada, or the class of 1 type of the Brugada during the, or the patient has got the developed Brugada during the VT. So these are some criteria. There are some specific criteria mentioned in this guidelines. So there are some criteria when the patient straight away needs the ICD. That is a beta blocker is the drug of the choice plus also ICD. That is positive family history, symptomatic. Symptomatic is the loss of consciousness, PDF, cardiac arrest, or the class 1 type of the ECG. So these are the groups of the patient, they need straight away the Brugada. See, other groups of the patient, there are some controversies. There are some incidental patients. We see the Brugada like ECG, but there is no history. Patient does not give any history, or there is no risk of the sudden death in their families. So these are the group of some of the patients who should be followed up. They are not the candidates straight away for the ICD. But class 1 ECG, whether the patient has got the syncope or not, or any kinds of the Brugada ECG with previous symptom or the positive family history, they are the candidates for the ICD. So patients of the Brugada should be given tremendous stress, importance, as because there is no in between life, either death or life. Mr. Bhai, am I clear? Or you can add some points.
No, every time I meet an electrophysiologist, I always feel myself to be very novice in that field. And you know how much patient I refer to you for this purpose. I'm really in this purpose.
Mr. Bhai, welcome to the club. I have the same feeling. Welcome to the club.
Professor Mahuram Babu is here with us first in a class.
I have another
question. Yeah, you had some.
Another observation. That is arrhythmogenic right ventricular dysplasia. Many echocardiographer nowadays has got a tendency to make the diagnosis of ARVD when they are getting any VT, and I think there are some over echocardiographic diagnosis on ARVD. And what is your impression about that?
True. For the evaluation of the RVOT PVC or the RVOT VT, this is the guideline rule. There's these groups of the patient who has got the PVC from the RVOT or the PVC from that is the RVOT VT. These groups of the patient should exclude the structural right ventricular cardiomyopathy, particularly the ARVD. So this is the way. So this is the reasons why you have to do the echocardiogram, particularly echo is the first. So echo is the essential modality for the evaluation of this, particularly the right ventricular outflow tract. There are some echocardiographic criteria, that is the dilatation of the alveoli, filling of the alveoli, punch out appearance, that is the fatty infiltration, convincing. So these are the, I am totally with Shadbhai. When we send the patient to see the RVOT, so they give some comment, yes, RVOT is mildly dilated, there is some thinning of the RVOT. So this is a help, but we cannot totally depend on this, as because this group of the patient actually needs cardiac MRI.
MRI. Yes.
So without cardiac MRI, only depending on the echo, still we do have the strong degree of suspicion, we should not take that decision. For the final decision, it is the cardiac MRI that is essential for differentiating between the whether the patient has got the RVOT dysfunction or not. Am I clear, Mr. Bhai?
Sir, in this respect, I have a question. To declare a patient as a structurally normal heart, what are the investigation we have to do before declaring a patient a structurally normal heart? Up to cardiac MRI, up to coronary angiogram, and like that. ECG echo is not always sufficient to visualize the structural integrity of the heart. So when we should declare structurally normal?
Yes, Khaliquzzaman is absolutely a very good question. Actually, in the guideline, that is ACC AHA guideline in 2019, there is update. There is a clear definition that structurally normal heart definition. It is that ischemic heart disease, cardiomyopathy, valvular heart disease, and coronary. If these 4 diseases are absent, then we can tell that this patient has got structurally normal heart. But
please mute everybody. Please mute everybody.
But structurally normal heart are not always structurally normal. There are some other abnormalities. What is the rare question? As for example, in case of infiltrated disease, particularly as this was sarcoidosis, this is uncommon, but this is curable disease. I have got experience of several 3 or 4 diseases. That is, sarcoidosis was diagnosed in Hyderabad, and the patient was cured. So sarcoidosis is one of the problems. ARVD is one of the problems. So these are the areas, that is cardiac MRI after the echo is the most important test for differentiating between whether the patient has got the rare type of the structural abnormality or not, particularly with the infiltrative disease or some diseases with the neuromuscular association, that is the ataxia like this. So this is the cardiac MRI. Cardiac MRI is the test.
Atahar bhai, can I ask something?
Sure.
ECG, echo, MRI. Do we need to have an angiogram to assert that this patient has a structurally normal heart?
Sure. As because if we want to exclude the coronary artery disease, which is the basic, most important coronary artery disease, unless we do the coronary angiogram, we cannot say this patient has got structure. So the coronary artery disease is the 80% cause. We have to exclude coronary artery disease, cardiomyopathy, valvular disease, and congenital heart disease. So angiogram is must to declare the coronary artery disease if we suspect. If we reasonably exclude by the ETT, that is another question. I have taken that the ETT is okay, so there is no need of the coronary angiogram. But we don't know. We cannot tell whether the patient has got the myocardial breeze. Even the myocardial breeze, LAD breeze, is one of the cause for the sudden cardiac death.
Sudden cardiac death.
VT. So sometimes, unless we academically, you cannot tell without the angiogram that this patient is structurally absolutely normal. But for the rare diseases, it is the cardiac MRI. Khaliquzzaman.
Thank you, sir. Sir, Deepal sir had another question. Which beta blocker will you choose for torsades pointis?
Mohsin?
Yes, sir.
Who is beta blocker torsades pointis?
Mainly, sir, metabolol succinate or the long-acting. This is the metabolol is the choice of drugs. It can be succinate or it can be Pactate. And sometimes, sir, propranolol can help, but the metabolol is the main choice of drugs.
Wadud bhai, add korben mone hoy?
One thing is that sotalol is effective in other drugs, but sotalol increases the acuity.
Right.
So it should not be, this being a beta blocker should not be used as a beta blocker in torsade.
I think this is the answer possibly people wanted to hear.
Thank you, sir. Very nice question, sir.
What about bisoprolol?
Is there any study regarding bisoprolol?
I have not heard. I haven't heard. Propanolol or metoprolol is the drug of choice, and propanolol.
If there is a LV dysfunction, we can, and in that case we can use the bisoprolol, sir. But normal LV function, in that case, sir, metoprolol is a choice of drug, sir.
I'm very fond of propanolol.
Thank you, sir.
Good job.
Sir, in your slide, you have shown that ranolazine is one of the antiarrhythmic drugs. What is the field of application and the mechanism of action of ranolazine as an antiarrhythmic agent?
Kalagazan, to give some comments. Yes, ranolazine is an emerging antiarrhythmic drug, particularly for the treatment of the atrial fibrillation. But the details mechanism, still I'm not ready to answer this question. Any panelist, or if you want to, you can share the answer to this question.
I have no answer in my pocket.
Initially, sir, ranolazine is an anti-ischemic drug. Now it is used, but initially it was discovered as an antiarrhythmic drug. But the main mechanism of action is not real, is known, but it is mainly used in the post-surgery atrial fibrillation. It is not effective in ventricular tachycardia. So far I know, sir.
I have got an important issue to be raised as regard coronary angiogram and the ventricular tachycardia. If a patient, we want to exclude the coronary artery disease who has got ventricular tachycardia, then should we go for straight coronary angiogram rather than doing for other stress tests? It seems that it is logical to exclude the coronary anatomy by coronary angiogram unless we will not be absolutely sure about that. So what should be the algorithm? If we suspect coronary artery disease, then we should not go for ETT and other stress tests, and we should go for coronary angiogram altogether, because this is real life problem that we encounter in almost in day-to-day practice.
সজল এরপর একটু কথা একটা কোশ্চেন করতে দিও আতার আলী স্যারকে।
আচ্ছা মেশকাত ভাই, আচ্ছা
মহসিন,
হ্যালো,
আচ্ছা হ্যালো,
আচ্ছা
মহসিন, can I ask any question?
Before that, Professor Mahbub Babu would something. Then Professor Amol Kumar. Professor Mahbub Babu. Then Professor Amol.
Unmute karo.
Yeah. Thank you. Amol sir korben. Sir, actually I have no question. Thank you, sir. Sir, I have no question, but you are not good. You are the best in this topic. A malignant tachyarrhythmia. You are the best, sir, and you're always you come with excellent topics and time-worthy topics, and it is very much. I was almost all the time, almost 1.5 hours with you in this class, and it is very much palatable and will be helpful for the fellows. And thank you, sir. You are really excellent and not only good, the best. Thank you, sir. Atahar sir, thank you.
Thank you.
I agree with Babu. I do agree with Babu.
Sir, Amol Kumar Chowdhury, sir.
Sir, I feel proud that I was with you pretty long time. Once upon a time, I was the assistant professor of you. Then 3 years. 2 times I was there, and I think this is the very critical topics today. What you have elaborately elicit the indication of any drug, Icd implantation was there. Everything I don't know, like I have no right, no knowledge to comment on your lecture. I have a question, sir. Simple day-to-day life. We are dealing lot of dilated cardiomyopathy patient of any etiology, particularly ischemic or doubtful idiopathy like this. When we feel that the patients cannot afford anything Holter shows the there is the significant criteria fulfilling the short-term VT. Even then, impending cardiac arrest like this, some malignant VT also there. So if we choose the drug, what are the drugs other than costly ICD implantation? What are the drugs we can use long time to prevent this type of moderate to malignant VT?
So thank you very much. Again, the same answer what the Professor Abdul Chowdhury already given tremendous emphasis to the use of the anti-failure drug. So anti-failure drug is the mainstay for the treatment of the whatever may be the etiology, ischemic and non-ischemic. You have mentioned about the non-ischemic cardiomyopathy. So it is the anti-failure drug that must be prescribed, guideline based. That is guideline as per guidelines says use the anti-failure drug. But one thing we must remember this class that despite the use of the anti-failure drug, there is a limitation of the anti-failure drug. Optimum use of the anti-failure drug for a optimum period of time, still the LV function is less than 40%, 35%, 30%. What to do? This is the question. So anti-failure drug, even we are using the anti-failure, proper optimum dosage of the anti-failure drug, guideline-based anti-failure drug, after the proper period of time, like the 6 characters, you reassess the ejection fraction. If the ejection fraction is less than 40%, less than 35%, you must follow the guidelines for the implantation of the ICD. If the patient cannot tolerate the ICD, we have limited options like the amiodarone. We have the very limited options like the amiodarone, and this is the only neutral drug that we can use. That is the less pro-arrhythmic pivot. Then the other drugs has got the actually some extra pro-arrhythmic effect. So it is the anti-failure that must give it, but after a point, there will be questions of the ICD versus the anti-arrhythmic drug. Am I clear, Amalda?
Yes, sir. Right. Thank you, sir. Thank you. Thank you.
Dr. Any question left in the box?
Farawid bin Faisal wanted to have few words about bidirectional VT.
I think
bidirectional VT.
I know actually. If you want to discuss, actually, Mohsin is very much interested about this topic. I have seen it several times. Mohsin, again, bidirectional VT, you want to comment?
The bidirectional VT, usually the morphology would be the amplitude upwards and next VT is downwards. This is a common scenario. It's commonly seen in the decoction toxicity and VT. This is the most usual. If the offending drug is withdrawn, then this is the main treatment of choice. And the CPVT is exercise. You can limit the exercise, and sometimes the patient need, if the patient has history of cardiac arrest, they need ICD implantation with beta blockers.
Thank you.
Tushar, do you have any question or comments? Asif Jaman Tushar, then Dr. Khalid Jaman.
Sir, good afternoon. I have a question, sir. Many a times there confusion arises between primary VT and secondary VT for the most of the students. How to define and how to differentiate primary VT from secondary VT?
Most important question, and it is the asked question in the exam also.
Yes. Frequently the questions that sometimes that is asked in the Viva board.
Yeah, yes, right, very nice question. Yeah.
But nowadays, the recent guidelines, this question is actually, I think, that is the primary, it is the time duration. It is the time duration, particularly in case of coronary disease or the myocardial, after the myocardial infection, that is the VT within the first 48 hours, that is the 30 minutes, VT within the first 48 hours, VT within the 6 weeks, VT after 1 month, like this. It is the time frame that difference the different categories of the VT and their importance. But as for example, previously we know that if the cause is reversible, whether the reversible cause is not, if the cause is reversible, it is the primary VT. Or if the reversible cause is not known, it is the secondary VT. But clinically, it is very much difficult to apply. For the patient evaluation, I don't think this is important issue. I have to classify whether the VT is primary. We have to see what are the reversible cause or not. For the any VT evaluation, we have to see it is the time of onset of the VT, it is the cause of the onset of the VT, whether the reversible cause present or not. So am I clear, Tushar?
Sir,
the recent guidelines to 219 update, I possibly don't see the term primary and secondary.
Actually, sometimes we confuse it with primary prevention and secondary prevention.
Right, exactly.
That's very well defined.
Yes, exactly.
Primary VT and secondary VT, as Atahar Bhai has said, we should be clearly differentiating between these two terminologies. One is prevention, and that is actual the VT classification.
Prognosis. What are the prognosis of the primary and secondary VT?
Khalik want to think. I think.
Khalik bhai, you answered about the prognosis of the primary.
এটা স্যার সবসময় একটা আলোচিত বিষয়, বিশেষ করে আমরা হয় we are student, তখন প্রথম দিকে একটা টাইম ফ্রেম ছিল within 48 hours of the myocardial infarction, that is which you have said primary VT, and after 48 hours. But within 48 hours prognosis is good in terms of mortality and morbidity, 30 days outcome or 6-month outcome. After 48 hours mortality is more. And another definition was at that time, and that was written in some books, that when the ventricular tachycardia is associated with hemodynamic instability, unstability, that is called the primary VT. And when the VT was not associated with hemodynamic instability, that is called secondary VT. That was once upon a time when I was a student, some books it was written. So,
Can I add something? Can I add something? Actually, it has been seen when the VT primarily is associated with an acute MI in the early phase, if the patient survives there, the patient gets proper treatment for the MI, that VT doesn't recur, doesn't have that much of a prognostic importance. And these are called primary VTs. Don't get afraid of this. Treat the cause properly, treat the VT properly, you don't have to worry. But after 48 hours, already the cardiac damage is done, extensive. Even after revascularization, the patient is not going to have the proper heart back. So there is always LV dysfunction. And any VT with that is likely to be secondary to the structural damage that the heart has sustained. And these VTs are likely to result in long-term increased mortality. They have increased chance of recurrence. And that's why this should be taken care of, not only by revascularization, but also by taking care of the other factors. And after 40 days, if the ejection fraction is low, then we may have to think about putting an ICD in there if the patient doesn't improve after an acute MI.
Can I add something?
Mohsin.
There's another way of classification. If there is no underlying cause is unknown, only PPC can initiate the VT and patient can die, or cardiac arrest. This is called primary VT. In that case, you ablate the PVC and patient will cure. If the patient cause is unknown, this is called secondary VT. This is another way of classification.
Simple question.
Just 1 minute. Yes, this is the concept on what the Professor Wadud already clearly described. That is whether the VT is in the initial phase, reversible, or the VT is the afterwards. That is the already substrate has developed, some structural abnormality has developed. That is not reversible. That the prognosis is better. So whether this term primary and secondary, what Mohsin is defined, whether the guidelines has mentioned this term.
No, see, this is written in the book, in the only the
previous books,
not the previous books in the. This is not in the guidelines, sir.
No. They are not differentiating this. This doesn't have actually.
I have a simple question to Atahar sir. What is the approach of the patient of frequent PVC? Number one.
Yes.
Approach is number one. Number two, if not treated, it can develop the cardiomyopathy.
PVC.
If what is the approach of patient management of PVC? Frequent PVC. Number one. If not managed PVC, it can develop the cardiomyopathy later on.
Yes, very good question too regarding the PVC, and this is one kind of this is the commonest arrhythmia of the human being, and this is the commonest ventricular arrhythmia, and we are always, but every time we always feel this group. So this is the very important question. Frequent PVC, always PVC evaluation. For the evaluation of the PVC, we have the same strategy we have to follow. that is evaluations of the VT. As because the PVC evaluation, we have to begin with whether this patient has got the structural heart disease or not. That is PVC. A PVC with structural heart disease, a PVC without structural heart disease. If the PVC with structural heart disease, we have to evaluate the PVC. We have to qualify the PVC as per guideline according to the cause. Whether this PVC is related with the HCM or PVC with the LV dysfunction or PVC with the ICM. Or if the PVC is structurally normal heart, possibly you are interested to know about this group of the patients. That is PVC with the structurally normal heart. Again, we have to see among the different things, really normal or not. This is the question actually previously discussed by the Meshkat sir. Really, we have to, by guidelines, we have to qualify the, that is, we can exclude the coronary disease, cardiomyopathy, valvular heart disease, and the congenital heart disease. If it is not present, then we can say it is structurally normal. But really normal, this is the question. What Khalikus are told. Then sometimes you need to qualify by the cardiac MRI. If this patient has got the fever, if this patient has got the sarcoidosis, we have to think this patient is getting the PVC. We have to think. If the patient some drugs for the 20 or 10 or 15 drugs, we have to think about the drugs is the cause. We have to think about the thyroid. So we have to analyze the patient. That is the cardiac problem and the systemic problem that can be associated with that. Both cardiac and systemic evaluation. If all the things are excluded, that is the patient does not have the systemic problem as well. Only the pure cardiac abnormality, yes, this of the patient, now we have to evaluate. So this is the number of the PVC, If it is, some says 10%, some says 50%, some says 20%, that is PVC burden. If the PVC burden is significant, they have to treat it. And PVC most of the time is curable by the ablation. So nowadays, the best modality of treatment, sometimes the drug, that is the beta blocker, calcium channel blocker is the drug. If the drug not works, cannot reduce the load, it is the ablation that can be done for the PVC. And the PVC burden is high. We are not ablating. This is one of the reason, rare cause for the cardiomyopathy. You are truly spoken. Thank you very much, Mohsin. Yes, this can induce the.
Can I add something?
Yes, yes.
One thing is that, so whenever we are going to deal with a patient with frequent PVC, we have to sure how frequent is this. The 12-lead ECG, we can occasionally have only 1 or 2 or 3 PVC, but patient is saying he often have palpitation, he often have these drop beats. We have to ascertain that by 24-hour Holter. Number 2, in the 12-lead ECG, look at the PVC. It is very near the tube. Is it multifocal? What is the relationship with the baseline ECG? Is there any evidence of ischemia? Is there any evidence of chamber enlargement? Is there any change in the ST segment? What is the QT interval? Is it very short? Is it very long? All these things actually should be taken into account, whether you are going to treat it very aggressively or to take some ameliorating action, like reducing tea, coffee, or using beta blocker or rate-limiting calcium channel blocker. And please, we are frequently underusing Holter. In these cases, a Holter sometimes let you decide whether you need to send the patient to EP specialist like Prof. Mohsin or Prof. Atahar. Because, very recent example, we have discussed that case. A patient, PVC, normal, LV function, no problem, mild dyslipidemia, otherwise good, he was obese, has reduced weight substantially, but still having that. He was given propafenol. We decided, why should he give him propafenol? We draw the drug, give him a washout period, we a 24-hour Holter. Patient never had any syncope, never had any dizziness. But when he did not have any antiarrhythmic, we find out he had non-sustained VTs. Multiple episodes of non-sustained VTs. We have talked, Atahar, Mohsin, and me. We both three actually talked about the patient over net. And then we decided we start a calcium channel blocker and also amiodarone. Wait 2 weeks, do a ECG again, Now the trigemini, bigemini, all are gone. The Holter shows no sustained VTs. The PVC frequency has gone down tremendously. Our next plan is to withdraw the amiodarone as well. Find out how is it doing. But our long-term plan, after the corona is gone, we are going for ablation. I'm going to send the patient our EP specialist. They will do the necessary action.
Sir, add something in the Holter, the morphology is different. Yes, sir.
Yes, and that patient, particular patient, we find out because we advocated for the ablation because some VTs had RBP morphology, some VTs had LBB morphology. It was if it was only RBP morphology, LBB morphology, then this patient has RBOT VT, and these are very unlikely to have sudden cardiac death. A rate-limiting calcium channel blocker would have done very well. But because it had double morphology, we decided that patient need amiodarone and he should be later on should undergo ablation.
Thank you, sir. Dr. Khaliquজ্জামান, did you want to some comments?
No, I have no comment now. Okay. Everything
we have already left.
Very details discussion, long time discussion, very fruitful discussion. Yeah.
Look at the time, how time flies by. Atahar bhai, you have done a wonderful job.
2 hours time. So complicated subjects we have collected.
No, I think it will take more 2 hours if we continue discussing the questions. Let us stop here.
I think
because of Professor Atahar.
আমার একটা কোশ্চেন আছে মহসিন, আমরা কি প্রাইমারি সেকেন্ডারি ভিটি কি আমরা বলবো না তাহলে এখন আর?
গাইডলাইনে নেই আসলে
কিন্তু আমরা যে হেমোডেমা হার্ট অ্যাটাকের একটা অ্যাকুট এমআই এক্সটেনসিভ অ্যান্টেরিয়র যে ভিটি নিয়ে প্রেজেন্ট করছে সেটা কি ভিটি হবে?
আচ্ছা দাদা, আমার মনে হয় যে বলতে নিষেধ নাই, কিন্তু ফেল করানো যাবে না।
Can I add something? Can I add something?
ফেল করানো যাবে না।
Actually this primary লেখা নাই আসলে বড় বইগুলোতে নাই।
Can I add something?
Yes.
This primary and secondary VD should be used only in case of acute MI setting. Please don't use it otherwise.
Yes.
Then that simplifies the
acute MI বলতে পারবো?
Yeah, I should agree. Yes. But that gives you help. You shouldn't worry that much. After 48 hours, if it happens, the patient needs monitoring because that patient is likely to have increased mortality due to sudden cardiac attack. That's the point. I think
thank you, sir.
We should stop.
আমার একটু স্যার কাছে একটা কোয়েরি ছিল স্যার। বলবো?
Mohsin বলো।
বলেন, আপনি কোয়েরি করলে তো স্টুডেন্ট
স্যারের কাছে।
Sure, sir.
স্যার অ্যান্টিডোমিক ট্যাকিকার্ডিয়ার সঙ্গে স্যার বিটি স্যার ক্লিনিক্যালি স্যার ইচিজি থেকে স্যার ডিফারেন্সিয়েটটা কোনো কাই আছে কিনা স্যার?
কোনটা?
অ্যান্টিডোমিক ট্যাকিকার্ডিয়া উইথ রেগুলার
Very difficult.
হ্যাঁ বলো।
Antidomic tachycardia and VT, how can you differentiate?
By ইচিজি থেকে পাইছে কিনা স্যার?
I don't know.
No.
It is
very difficult unless we
can you use adenosine in that case as a diagnostic tool?
And one is actually in chat box I have seen one question, and particularly regarding this question, this is an important issue. I think to discuss the audience.
Amata, silent please.
Mute please. Mute please.
Amata mute kar de. Mute kar.
For the antidromic tachycardia, actually we have to apply all the that is a Brugada and the Ecg algorithm criteria, but practically the most 100% specific criteria for the VT diagnosis, unless we see it, we hesitate to diagnosis, that is the AV dissociation. In case of the classic ECG, it is present in 30% of the cases, but if we see it, we are 100% convinced. I think from an assumption, this is an important question that I will think afterwards, what Mohsin has raised, that is in case of the antidromic tachycardia. I think if we see clearly, very carefully, we can see that is the AV association, that is VA association in case of antidromic tachycardia. That is the regular inverted P waves, that is the association, that is dissociation will be absent. This may be one of the clue. That is this wide complex tachycardia may be the antidromic tachycardia, Prof. Mohsin answer. And another question, that is there is a question in the chat was that There is in case of the antitropic tachycardia or the atrial fibrillation, the WPW syndrome, that is the adenosine is contraindicated. In case of the, if we know that is this patient has the WPW and the atrial fibrillation, then we should not use the adenosine. This is the only area where we should avoid that. That is, we should avoid the adenosine.
Achha, can I add something?
Yes, sure.
Yes, sir.
In our ECG setting, if you use 40 Hertz filter, then the small waves, the small P waves actually cannot be seen. The 12-lead ECG should always be recorded with 150 Hertz filter. Only then actually these low amplitude waves can be actually seen. That's why in most of this ECG, you cannot actually see any P wave. And you actually cannot see most of the dual chamber pacemaker ECG spikes.
True.
Okay, sir. Sir, we have to stop now because 2 hours waiting lecture after a discussion. I think everybody are, especially me and faculty is also, I think, delighted by your lecture, sir. Thank you, Professor Atahar, sir, being with us. Stay safe and take care, sir. Professor Wadud, sir, please tell something.
What should I say? This is a lecture that actually makes you so happy because a complex thing elaborated so beautifully in a very simple language, in a simple way that actually you can understand. Only a genius can give out such a presentation. Professor Atahar, sir, we are really grateful and we are really proud to have you with us and to have this presentation that we can present for everybody. Thanks to the audience, thanks to the senior teachers, and thanks Inceptor Pharmaceuticals for arranging such beautiful webinars. And Professor Atahar, sir, again, my hats off to you.
Sir, also thanks to Professor Wadud Chowdhury and Mohsin for arranging such a nice session.
Thank you.
Thank you. Thank you all. Thank you, participants. Being we are running the shocking time with the COVID era, we lost lots of friends. And as Professor Wadud know, during the program, I and Wadud sir managed my own relatives in the CMS, CMS. So my wife is there, he is there. But we are doing, running this program. It is our duty to continue our program because our participants is our strength. Our panelists is our strength. Professor Atahar sir here, Professor Jalal sir here, Amal sir, and Bahura Babu and Mohsin sir, everybody here. Thank you, Dr. Shikat sir, being with us. Our next class on 7th July, on Tuesday.
Mohsin, yeah.
Yeah, something, sir?
After you, I want to have a announcement after you.
Yes, sir. Yes, sir.
Today,
yes, sir. Please.
Today at 10 at night, we are going to have a lecture from our ECD study group. Today's lecture is our second lecture on the fundamentals of ECG. So anybody who is interested, they can join in. We have posted a link in the previous forum.
Thank you, sir.
10 p.m.
Okay, thank you, sir.
7 তারিখে মহসিন 7 তারিখে কিসের উপর লেকচার আছে 7 তারিখে
on 7th Tuesday at 3 o'clock Professor Mamun Rashid will talk lecture on cardiomyopathy. Till then, stay safe and take care.
And goodbye. কবে স্যার?
আজকে রাত 10টায়।
রাত 10টায়। রাত 10টায় আমার লেকচার আছে একটা। আজকে রাতে আমার লেকচার আছে। আমাদের এসিডি স্টাডি গ্রুপের পক্ষ থেকে এই আতার ভাই আমিই থাকব আর কি।
Thank you, Atahar sir. Thank you, Atahar sir.
Wadud sir.
Wadud এটা লিংক পাইনি কিন্তু Wadud লিংক পাইনি।
ফোরামে তো আছে তো।
আমি পাঠিয়ে দেব স্যার, আমি পাঠিয়ে দেব স্যার।
সঞ্জয় তুমি সব ফোরামে পাঠিয়ে দাও।
আমি এখনই পাঠিয়ে দিচ্ছি স্যার। আমি এখনই দিয়ে দিচ্ছি স্যার। আমি সবাইকে পাঠিয়ে দিচ্ছি স্যার এখন।
মিস্টার স্যার চালা স্যার এদেরকে পাঠাও।
কি ওই বিআইটি প্রোগ্রাম আছে তারপরে
বিআইটি প্রোগ্রামের পরে।
হ্যাঁ ওইটাতে Wadud থাকবে, আমি থাকবো, রফিক স্যারও থাকবে।
আচ্ছা স্যার রফিক স্যার ভালো।
We also thank Inceptor. They are doing a tremendous job last months, and as well Dr. Arifur Rahman Sajal and মানে কি বলবো কোনো টায়ার্ড হন না, আনটায়ার্ডলেস জব প্রফেসর ওয়াদুদ স্যার। থ্যাংক ইউ ওয়াদুদ স্যার, থ্যাংক ইউ, থ্যাংক ইউ জালাল স্যার,
থ্যাংক ইউ স্যার,
থ্যাংক ইউ স্যার,
আসসালামু আলাইকুম স্যার।